Right. I mean,
I don't do Yoruba.
Danny boy. Daniel. Come. That cocoyam remaining alcohol. Huh? Peel it. See why I peel it down. Then take the things that they want the plenty one. Leave the other small one. Tomorrow you used to eat rice. When you put palm oil, look for that small. This is a pepper ceremony. I dry it. You just pound small, maybe about 6 fingers. Huh? Says in one form, about 6 fingers. You pound it. You stir it. Then you take a Maggi, put like 2. Okay. When you stir it, leave it to cook more. When you cook small, you put the potatoes first. So the cocoyam first. About 5 minutes or so. 5-10 minutes. Okay. When it has boiled, you now bring the. When you finish, let me know. I want to attend one workshop now.
I'm delay in transportation. My clean up others. I postponed. The answer governor I go out of commission project. Yeah. Yeah, imagine
What would you recommend to the ones who have been on some spaces? There are those who also say that the federal government actually ask them that they are going to cause motion and there are those who are already saying burn down their
No. Okay. Yes, sir. Huh? Agak banyak. Hello. Now the pizza from my house.
Ṣé omi náà ló ń fọdún kan gbé látẹ̀ǹkan wá? Him.
Kanin da irin ba kwanon su.
Windows are locked.
How did you much? How did you much?
Come on, Abena.
Is that the smaller?
Asalin
Hey. Maybe I'm going to say, man, at the smaller.
It's okay now. It's contracted.
Wow. Sorry, I thought. Sorry. I thought we have reached. I know you.
Daddy, Daddy say you want to. I can't do the after that. Nǹkan tó ń dó jẹ náà kó jí owó ṣe ń sáré.
The Zoom meeting on audio they sent.
No. This is your own now. Or you are eating it, you are still picking up to party. What? You open your mouth. Open your mouth. You're taking from there. Do you want to feed it to what now? Your mother do this now. Okay. Number in Korea pé na sai fún.
Never. Wow. Come on, eat already.
Hello, good morning.
Good
Hello.
morning.
Can you hear me?
Good morning, sir.
Yeah, good morning.
Can you see my screen?
Yes.
Yes.
Okay. Good morning, all. My name is Naziru Bashir Mukhtar. I am a musculoskeletal physiotherapist from Bayero University, Kano. I will be taking the first aspect of today's workshop, while my colleague, Dr. Bashir Kaka, will take the second aspect of the presentation. Are you with me? I want to make sure that everyone is with me before I continue. Okay, we had some issues with starting the program because I wanted to start it at a specific venue and I forgot that there is a sanitation in Kano. So roads are only open by 10 in the morning. So that's why there was a little delay in starting the workshop. So I think if the participants, I can see the participants, the number is big. I don't know whether if it is possible to just have maybe just one sentence introduction, name, where someone works. At least that will guide me on how I should take my presentation. Maybe you can unmute yourself and just say who you are and where you work. Yes.
Hello.
Yeah, Suleiman Sani Usman.
My name is Sulaiman Sani Usman Borzo. I graduate from Bayero University, Kano, but now I am working in Federal Teaching Hospital, Lafaja.
Okay, so a full-time clinician. Okay, next.
Hello, good morning, Dr. Nazir.
Yes.
Hello, good morning, Dr. Nazir. My name is Mubarak Awakar Falke, working from Unguru, Yobe State.
Okay, another full-time clinician. Maybe we will see all clinicians, okay?
Good morning. I am Rashida Zibiri, a lecturer with Kaduna Polytechnic, Department of Special Needs and Rehabilitation Science.
Okay. I'm getting someone who is an academic like me, okay?
Good morning, all. I am Ransom Udi. I work at the Porter Specialist Hospital, Jos. It's an orthopedic center. Thank you.
Okay, you're welcome, sir. Okay.
Good morning. I'm Anekwe Oluchukwu. I work with National Orthopedic Hospital, Enugu.
Okay.
Good morning, everyone. I am Kingwe Zekaf. I work with Physioplus Associates.
Okay. It's a private physiotherapy clinic?
Yes.
Okay.
Yes.
Okay.
In VI.
Okay. Yes.
Good morning, all. Can you hear me?
We can hear you. Midai Samuel, yes?
Midai Samuel, General Hospital, Mubi, Adamawa State.
Okay. Yes?
Good morning. Omodigbo Omoleye Elizabeth, working with State Hospital in Ogun State.
Okay. Okay.
Good morning. My name is I work with Laro.
Yeah, I can't hear you well.
I work with State Hospital Ilaro.
Ilaro. Okay. Yes, next.
Okay.
Good morning, everyone. Good morning.
Good morning.
I am Adeyemo Mojirade. I work at the Redeemers Health Center, Redemption Camp in Ogun State.
Okay.
Good morning, everyone.
Yes, good morning.
Is my name. The Lagos State Sports Commission.
Okay. So I think because of the big number of the participants, I now have an idea of what constitutes my participants. So I think I can go ahead with my presentation. Yes.
You can go ahead, sir.
Okay. So my slides are showing on your screen?
Yes, they are showing.
Okay. So as part of the introduction, I said my name is Naziru Bashir Mukhtar. I am a physiotherapist. I graduated from Bayero University, Kano in 2008. I did my internship in University of Maiduguri Teaching Hospital and my National Youth Service in University of Ilorin Teaching Hospital. And after that, I have worked with National Orthopedic Hospital for some years before I joined Bayero University, Kano. I obtained my master's degree from Vincent Paul University in Lublin in Poland and my PhD in Ghent University in Belgium. I'm presently a senior lecturer with the Department of Physiotherapy, Bayero University, Kano, and a visiting assistant professor with the Department of Physiotherapy, Mariam Abacha, American University of Nigeria. So I can say I'm going to talk in two perspectives. Presently, I can say I'm a part-time clinician because I see patients privately. And then I have had the experience of working with orthopedic patients for quite a long time. And my area of specialization, even though musculoskeletal physiotherapy, I am more concerned with chronic pain, especially in the spine. So a lot of my research and presentations are in the upper and lower spine. So neck pain is part of my area of interest. And my PhD was on development of some culturally sensitive tools that can be used to manage patients with chronic spinal pain, either neck pain, thoracic pain, or back pain. So the component given to me in this presentation is to discuss with my senior colleagues and colleagues on neck pain assessment or examination, while my other colleague will talk about the management of neck pain. I intended to cover this synopsis, general overview of neck pain. This is what is showing. Hello?
Yes, sir.
Hear you.
It's like my slides are not showing.
It is
They are
showing.
not showing. They are not showing.
It's showing. I can see it.
Can you see the synopsis?
No.
No.
Oh, then my slides are not moving.
Yes.
You said?
The slides are not moving.
Okay. And now?
Yes.
Okay. So it's okay now?
Yes, it is okay.
Okay now.
So yeah, so I'm going to discuss, my previous slide, this is the introductory slide. So I have put a copyrighted drawing there. You can see it is part of my copyrighted drawings that I used for my PhD because of the culturally sensitive tool I developed for the management of neck pain and back pain. So the synopsis I'm going to cover, we will have a short general overview of neck pain. Then we will discuss possible causes of pain and or limitation of movement in the neck. Because basically, physiotherapists manage the pain or limitation of movement in the neck. Then we'll talk about subjective examination, where we will now discuss about the importance of using body charts in assessment of neck pain, behavior of symptoms, how we take the history of present condition, relevant medical history, social and family history, how we plan the physical examination, Then we go ahead with the physical examination. How do we observe the patients? There are specific passive intervertebral examination that we do carry. Then neurodynamic tests, joint range of motion assessment, then sustained natural artificial glides, SNACs, muscle tests. Then we will discuss outcome measure administration, because we can administer them as an assessment tool and we can administer them to check progress of our intervention. Then we will check the relevance of laboratory and radiological investigations, and then we'll try to complete how examination should be. Well, before I go ahead, if I can have 2 or 3 of the participants maybe to say what they expect from the presentation, if it makes sense, because sometimes the expectation may vary from what the presenter is presenting. If I can have 2 or 3 volunteers to tell me the expectations from the presentation, then it will help in guiding me making the presentation. Yes?
During the course, can you hear me?
Yes, Vivian.
So during the course of the presentation, I would like to know how to properly assess neck pain and also how to differentiate between radiating and non-radiating pains. Just how to properly assess a neck pain to find out the particular problem the patient is having, whether it's radiating or not, and there.
Okay, and do you expect it to be practical?
Next economics.
Or you expect that you should be guided?
Anyone, practical or not, is okay.
Okay. Yeah. Yes, another
Assalamu alaikum, sir.
volunteer. Alaikum salam.
So what I expect from the presentation is how to make an examination of neck pain, management, differential diagnosis, and then sometimes preventions. Prevention.
Okay. I think some of the components you are expecting, they should be covered by the second presenter. Anything that has to do with management or prevention will be for the second presenter. I am expected to discuss how to examine, and then at the end of the examination, then how you plan the management will be taken by the second presenter. Thank you for saying your own view of the presentation. Then maybe third volunteer.
Assalamu alaikum.
Alaikum salam.
Good morning, sir. So my expectation is to see that like the way you make the synopsis, subjective assessment, objective assessment, to see that is there any new evidence, is there any other things that we can add to what we currently, to the existence, what we are doing. That's my expectation.
Okay. So do we need to take another volunteer, or we now go ahead? So I think we can now go ahead. Yes. So in the plan of my presentation, of course, I'm going to discuss about the neck pain, how we differentiate it from other symptoms, if there is a radiating pain, how we should examine the radiating pain. So I think it's part of it. Prevention, probably maybe the second presenter is going to talk about it. Yes, the evidence, most especially those that read papers, research papers. We have also evidence to discuss. We can have different level of evidences. There are evidences in the management. So probably my other colleague will discuss that. But there are also evidence in the examination. What should be done and what has shown to be reliable, valid in the examination of neck pain by evidence, because there may be some other assessments, some other tests we do that probably they are not yielding results, probably they are not reliable or they are not valid, but we still do them. So what I'm going to present is based on the evidence that these assessments are helpful. Where there are no evidence, I will highlight that there are still some issues with using such assessments or examinations. So as part of the overview, part of the presentation is that I think neck pain is an important component of our treatment that we need to handle. And unfortunately, in research, if not recently, most of the researchers in the clinics and in the academics, they put more focus on low back pain while leaving behind neck pain. But recently, we are having many research interests and many papers presented regarding neck pain. So we are having much interest in that. So neck pain is one of the most common musculoskeletal disorders, having an age-standardized prevalence of 27 individuals per 1,000. And this is relatively a recent review in 2019. I don't know, probably maybe if another one will be conducted recently, if we will see some differences. Unfortunately, we don't have specific prevalence study in Africa to see how prevalent this disorder is. I am currently conducting a systematic review. I have published the protocol of the systematic review to find out the prevalence of neck pain in Africa. And I think if at the end of the review we publish it, then we can have figures at hand that we can see how serious this disorder is in Africa. But we can still use the global one to focus that this is the disorder that is affecting individuals globally, but it doesn't cover much of the African data. The economic burden of neck pain is remarkable and includes treatment costs, reduced productivity, and job-related problems. And unfortunately, many of our colleagues, except those that are practicing maybe abroad, these items are not much taken into consideration when we manage patients. We hardly sit with patients and discuss the cost of the management. For example, if you are managing a patient and you think the most effective way to manage this patient is if he can afford maybe 3 treatment sessions in a week, that should last for a minimum of 6 weeks. And then you now sit the patient, explain the costs, explain the implication, and the implication of the outcome if these frequencies or this duration is not covered. So this is one of the areas that probably when we are managing patients, subsequently we have to take into consideration. Sometimes because of the cost, a patient may say he will afford only once in a week. So as a clinician, you have to devise a means through which those missing number of sessions that have been found to be effective, how they will be compensated. If the patient, because of the cost, can only afford 1 treatment session in a week, and you know from evidence, and you know from evidence that this is not going to help the patient, then devise a means through which those missing components will be compensated. The typical home programs we give, we have to change the order we give so that it will be like how a patient will self-manage himself. Then reduced productivity. We hardly also notice this from the participants, so we need to also take this into consideration, how it affects someone's work, what is expected of that individual, what he can accomplish or she can accomplish within a certain period of time before the ailment and now. So we need to take all this into consideration. So I used the definition of global burden of diseases of 2005 to define the neck pain, which is an activity limiting pain in the neck region. The definition of the area, usually from the superior nuchal line to the level of the C7 spine and to the edges of the scapula bilaterally. So anatomically, it is beyond just neck region, but clinically, All this area is defined as part of the neck, and if there is pain there, it is a neck pain because the structures there are interrelated. It's like my slides are not moving.
A little bit there, and that all started they're not moving.
Yeah.
Right, quite far back, might be over to one side, and then it's all gone to fitting. Like they need another meter, or then actually the water. Like to see the toes a little bit more expensive as well as the aesthetic. 57.6 on that dime, pretty great. 45.2. 3 rounds are complete. Rounds to go, and we will know.
I have to get some technical assistance. Habis, what's happening with my slides?
Here are the rankings. Coming out 10 points clear. USA, second place, Australia
Not
now.
progressing.
Third place. Actually, well, I'm quite well ahead of Italy. Ukraine and France. We get to this event, tennis favorites and are leading the event.
Okay. So now we move on to neck pain classification, because at the end of the assessment, there is someone that has not muted his mic and it's distracting us. Okay, so clinicians are expected to classify their neck pain because that classification is going to guide them in the management of the neck pain at the end. So motion limitation is part of it in the cervical and upper thoracic region, whether if the neck pain the individual is presenting with, there is limitation of neck movement in the cervical and thoracic regions. Then presence of cervicogenic headache. Most of our clinicians, they hardly take into consideration the presence or absence of headache in the neck pain they are examining. Then history of trauma, this one we always take into consideration if there is trauma, and then referred or radiating pain into an upper extremity. We also take this into consideration a lot. So the two major things that we need to now put more focus is the presence of headache. A lot of neck pains, they come up together with headache. So we need to assess and see if there is headache or there isn't headache in the presentation of the patient. So based on that, we can categorize the neck pain of the individual as neck pain with mobility deficits, maybe to the right, to the left, in extension, in flexion, whatever, or overall body movements. Then neck pain with movement coordination impairments, especially when there is whiplash-associated disorder. Then neck pain with headaches, especially cervicogenic headache. Then neck pain with radiating pain, with radiculopathy. So in each of the 4 categories, then we can now classify the pain to be acute, subacute, or chronic. So if we know that this is the type of pain an individual is having, and it is the acute one, which is at the subacute stage, or it's at the chronic stage, then we can be able to successfully manage, assess the pain, and then plan for its management. So some important questions when the patient is seated before you presenting his or her complaints is, why is that patient in pain? So the first thought will be, is there any underlying sinister that causes the patient to be in pain? And from the information you get in that individual, then you should be able to, I think, set your mind at what you are going to expect from the patient. There is this misunderstanding among many clinicians, and I think this is something that we should work towards changing. In most of the presentations, immediately a patient is seated before you with pain, what comes into your mind is there should be a pathology related to it. Of course, if the presentation of the patient is acute, it's much expected. But if the presentation is at chronic stage, it's less expected, unless if there are red flags. In most of the chronic painful conditions that we manage, there may not be pathology. We are going to discuss that subsequently. So if it is at its emergency stage, the pain, then you should consider serious underlying concerns like fracture, because most of our examinations are manual. So we have to make sure that we have ruled out all other pathologies that may prevent us from manually examining our patients. If from the information we get, we are suspecting fracture, we are suspecting dislocation in the cervical region, or other structural injury requiring special care and or surgical correction. So with this, probably we may stop at maybe just examining the patient subjectively, not touching the patient manually. If there is structural instability, then we get the details of other related conditions. And if we are suspecting infections, cancer, systemic diseases, inflammatory arthritis, neurologic compromise, all these ones will guide us whether if we are going to examine the patient manually or we are going to make referral of our patient. So in the context of the neck pain task force mandate evaluating neck pain without serious underlying structural disease, the next clinical question is, what is the problem and what is this patient's likely prognosis? If you have asked the first question and you realize there are no other red flags that will stop you from examining the patient, so now you know this patient is meant for me. So what is the problem of the patient? And is this a likely progressive condition, or is a condition that I can easily handle and the patient will get better? So at this point, the clinician may or may not order further diagnostic testing and discuss treatment options with the patient. If you still have some information that you think may not guide you well, you may, if there is need, request for some diagnostic investigations so that you will handle the patient very well. But if there isn't, then you can go ahead and examine the patient. So we may need to discuss a little of the anatomy, the biomechanical structures. Do I need to connect to that internet? I think my slides and my voice is still okay, yes? Okay. So we know in the cervical region, we can discuss about the bones in the area. We can talk about the musculature in the area. Then we can talk about the cardiovascular system, then the nervous system. So there are some sensitive structures around the area that we need to take into consideration while assessing our patient. So we know the upper cervical region is the most mobile region because of the anatomy of the attachment of the first and the second cervical and the skull. We know the atlas, how the articulation with the skull, and it will allow movements to take place in different axes. And then how the axis provides other articulating structure that attaches also to the skull, the odontoid process. And then with this, then there is permission for free movements in the region, and the absence of the intervertebral disc also help in that region. So we hardly find limitations of movement that are very normal in that region. But in subsequent lower regions, maybe because of the intervertebral disc or other structures, then movements are to some extent limited, but not in the upper cervical region. And then the muscles around the area also are very relevant, because sometimes we put our attention much thinking that it is the joint that has a pathology, and probably maybe the problem is in the muscles. I know in our curriculum, we hardly teach about trigger points and then disorders of the muscles. So all the tensions in the muscles are not properly examined by clinicians. And sometimes we go ahead to treat patients thinking that we are managing joint disorders, while probably maybe it is a musculature disorder. And then another important thing to consider, apart from the nerves, also is the cervical arteries. So for example, the vertebral artery, we can pinpoint there in red. It is immediately below the skull and lying above the first cervical vertebra. And with side movements and rotations, it can easily be compressed. So that is why we need to make sure the patient is fit for our examination before we go ahead, because compressing this can easily cause ischemia, and it may be deleterious to our patient because it may lead to other serious issues like dizziness, headache, and sometimes patients may collapse. And in some extreme cases, we may lose a patient with that. So now, if we have briefly discussed the neck pain, we have briefly discussed some of the possible causes of pain and or limitation of movement in the neck. The first one we will talk about is trauma. A lot of our patients that come probably maybe because there was a whiplash. Maybe they are sitting as passengers or drivers in a vehicle, and then there was a head-on collision, and then there is this oscillatory movement of the neck that can be termed as whiplash injury. Then some, maybe because of sports or occupational injuries, sustained neck extension or neck flexion occupations, they may predispose someone to trauma. And then sports, mostly contact sports, where individuals can easily fall down and then they can sustain injuries. Then fracture of spinal body, spinous process or transverse process. Then ligamentous sprain, muscular strain, all these ones. Then spondylosis. For spondylosis, I'm going to discuss more about it, because most of the times that we diagnose patients with spondylosis and say we are going to manage the spondylosis, for spondylosis, we only need to manage if there are symptoms, because radiographs may be misguiding clinicians. I am an advocate of using less of such investigative aids, unless if there is their need for using them, because they misguide the patient, they misguide the clinician. An acute pain situation, there may be need for you to rule out some other pathologies, so you may use the radiographs. But if it is a chronic pain condition and you are examining the patient, if you go ahead and request for radiographs, for example, to say, okay, this patient has these degenerative changes in the joint, has this, and then you use it to explain to the patient, because the concept of management of patient in evidence-based practice now is you discuss with the patient and explain everything. So if you do that, probably the patient is having different presentation, not due to that spondylosis, because changes that are due to degeneration, they are pathological, they are normal. With aging, you're expected to have such changes, but not all those changes will present with symptoms. You may have a patient with chronic pain not having such remarkable degenerative changes in the spine. And you may have someone that doesn't have symptoms, that probably if you are working in the clinic, the patient or the individual is at home, and then you are given the radiograph of that individual that this is my patient. By looking at maybe the radiograph, you may prescribe some exercises, maybe even ask him to use a cervical collar, use this, because you think with these changes, the patient must be in trouble. And that probably that individual doesn't have even 1/10 of pain in a rating score. So you should be careful with how you interpret someone to have spondylosis and how you manage the individual. And how we explain to them as clinicians, we hardly rate the fear of the patients. So in the modern way of patients management, we have to be very careful with how we explain to our patients what we are seeing now from some laboratory or radiographic investigations. If you tell the person that there are degenerations here, there are this, and you use all those big grammars, then that individual may end up having fear that he shouldn't be moving the neck. He has a serious problem. It may end up requiring surgery. It may end up this, it may end up this. And then that fear will now make the patient to get worse. The outcome will get worse. Will be afraid to move the neck, will be afraid to do some other functional activities, and then you have contributed to the worsening of the condition of the patient. So apart from trauma, then probably cervical rib also contributes to pain around the neck region. So that's why sometimes with movements, you may be able to see if there are some changes. For example, movements that will depress the scapula and movements that will now elevate the scapula or the shoulder, then they will show you if maybe there is associated cervical rib presentation or not. Where structures around the cervical rib are compressed, like in depression, then there will be exacerbation of symptom. Where cervical structures that relieve cervical ribs, like elevation, will now relieve presentation. Then hypermobility syndrome. Sometimes, although the neck region is very mobile, but sometimes the movement there may be more than physiologic. So the neck can easily try to give away. It can easily fall by the side, fall anteriorly or posteriorly, where the movements are beyond the physiological ranges. Then thoracic outlet syndrome also may present with symptoms in the neck. Cardiovascular diseases, we just talk about the cervical arterial dysfunction, how they can easily be compressed. Then if there are inflammations going on, we hardly find active inflammations there, but if there are some other systemic disorders there, then we may have swollen neck, and then it may precipitate pain in the neck region. Then probably maybe rheumatoid arthritis, ankylosing spondylitis. We often see this, which covers the cervical and then thoracic region. Then cancerous presentations may also be reasons to have pain in the neck region, infections, torticollis, then headache, migraine, tension type headache, cluster headache. All this, if we have this at the back of our mind, then we know that we have a lot of things that we may think they are the reasons for the presentation of the neck pain of our patients. But I'm still cautioning that all these thinkings are more important in acute and subacute presentations. Do not always think in this direction if the patient is having chronic presentation, because you need to expand your own thought so that you will know if maybe it is the system that is faulty, not that there are structures. There is concept of neck development in which we are expected to have a normal pain regulatory system where information is taken to the brain and the brain will interpret the information. And then if there are levels of danger, then it is expected that the brain will interpret it as pain, then we get the pain. So in acute stage, this is the normal procedure. But in chronic stage, probably this system is faulty. Maybe the danger is no more there, but the system is faulty, is still taking the information to the brain, and then the brain is still interpreting it as pain. So in that case, probably maybe with some other active interventions, then the individual will now, and also with proper education, the individual will now get the system back to normal, and then the pain will start to disappear. So for the subjective examination, maybe in the private practice, but in public centers, we hardly use the body chart. But for those practicing abroad and maybe in private centers where you need to be more responsible for the patients, then body charts are often used and they guide the patient. Sometimes the terminology you're going to use is not so familiar with the patient, but if you will see a drawing and then you will ask where the symptoms are, then the patient can easily pinpoint, I have it here, it sometimes come down to here, it sometimes get to here. So you can easily map out where the patient is having presentations, and you can see if clearly the patient is having neck pain presentation or not. So it is encouraging that if we can have body charts in our assessment file so that we can easily pinpoint where the patient is having some symptoms. So if we have taken care of all this, then we can go and relate those information with some biodata of the individual. The age, if you are assessing a patient, probably, for example, the spondylosis that I mentioned earlier, there is no way that you will see someone that is aged 70 years, 80 years, over 60, that you will not see degeneration in the spine. If you get the radiograph of the neck region, probably that's where the patient is having the pain. And then the patient has remarkable degenerative changes there. And you want to relate that to the degeneration. Probably if you will ask the same patient to go and do lumbar spine radiograph, you will see more degeneration there than the one in the neck. And probably the patient doesn't have pain in the lower lumbar region. So it's maybe misguided. So if this is the age I'm seeing, then it should guide me that when I see a result, whether if that result should be frightening or not. If it's a young individual, maybe of 18, 20, 30, and I see remarkable degeneration, I need to probe the patient more, maybe about the physical activities, maybe about other systemic disorders. Probably I will get more information why the spine should be so degenerative like that. Then the gender, it is important also, especially when we talk about joint laxity, hypermobility. We know that female genders mostly, because of the hormonal system they have, the variation with the men, then they have more mobile joints and they have more tendency for hypermobilities than the male gender. Then ethnicity, because we are now discussing about pain and how different ethnic groups express pain is different. So if I am handling, for example, a Fulani patient, that probably on the visual analog scale I'm assessing, and the patient is saying probably maybe out of 10, if I measure, maybe it's saying 3 or 4. And on the other hand, I'm assessing maybe a Yoruba patient, and the patient is also saying 3 or 4. For sure, I should be more careful on how I manage the Fulani patient, because it is documented in the literature how they express pain is very less. So a serious pain may be expressed to be a very low pain by Fulanis. So the way I manage should be different, and the way I also take into consideration how that pain is. As I score the pain, I may ask how that pain may limit some activities so that I will know how serious the pain is. So the ethnic and then can be connected with the cultural and social background, because some of the activities someone does will now determine if he can easily express pain or endure pain so much. Then the occupation, most of the times we need to relate the pain, the presentation with the occupation of the individual, because it may affect the occupation, and that occupation may be the reason why the patient is presenting. If he will be back to his normal occupation, he can endure the pain. So I've already talked about the chart. So we have to be very exact when mapping out the area of the symptoms. So if you are not using a chart, it may be difficult because you will only say pain in the upper cervical region, pain in the lower cervical region, pain over the right shoulder region. It may not be very, very specific, but if you have used the chart, then you can see from where and where the patient has expressed the pain reaches, and then you can easily know the exact area you are handling. Patient with upper cervical spine disorders have neck pain high up and around the occiput and pain over the head and over the face. So for individual patients that are presenting with pain around the face and the head, we need to make adequate examination of the upper cervical region, atlanto-occipital joint, then atlanto-axial joint. Probably we may find some reasons for the production of the pain. And then that pain is as a result of the neck affectation. The head pain is as a result of neck affectation, not specifically maybe because it is an independent headache. Then ascertain the worst symptoms and record where the patient feels the symptoms are coming from. This is subjective. You ask, all this I am presenting now, we haven't touched the patient, because all these are the ones that will guide us on touching the patient or not touching the patient. So where do you have the worst pain? Let them point. So if you are indicating in the chart, you can now indicate, probably maybe if you are using asterisk, to now indicate where the patient is having pain, maybe where the patient has the worst symptoms, you will now use double asterisk, or you would use triple asterisk to show that patient is having irritable, very serious, severe pain. Then probably some of the examinations that we take that exacerbate pain have to be avoided till after some sessions of interventions. So areas that probably we need to examine when we are handling patients with neck pain: we need to examine the head, we need to examine the teeth. For the head, we know upper cervical pain can easily present as headache in the occiput, headache, pain in the anterior aspect of the head. Then teeth, mostly pains that are of muscular origin. For example, if someone is having trigger points over the trapezius muscle, it can easily radiate into the teeth of the patient. And sometimes the patient may even go to see a dentist because he's having serious toothache, not knowing that this is a radiating pain from the trapezius muscle. Sometimes you may try and see among your patients those that have serious tightness of trapezius muscle, that have tenderness there, while given compression test to the trapezius muscle, they will tell you that they have symptoms over their teeth. Then temporomandibular joint also, because sometimes the patient will present with worsening pain, maybe when they are opening their mouth wide, specifically from the temporomandibular joint or from the neck. Then thoracic spine, since they are interconnected. So you have to also examine and make sure that the patient's pain is not from there. Then shoulder, elbow, wrist, and hand. These are the areas where the nerves that exit from the cervical spine passes and innervates. So because they passes and innervate there, you also need to also examine the area. Is it a pain due to radiculopathy, or the patient is having independent pain in the shoulder, independent pain probably in the elbow or in the wrist, or it is an associated pain due to compression of the nerve roots of the cervical, of the brachial plexus. Then make sure that you also examine if that patient is having disequilibrium and then dizziness. any of these presentation may limit the extent to which we examine the patient because they are indicative of cervical arterial dysfunction. And if there is cervical arterial dysfunction, then we need to be careful with how we manage how we examine the patient. It's not everything that we examine. So the most of the complaints is not about range of motion. Usually it's about pain. Even if it is related to range of motion, your patients will say, when I move here, serious pain. So still is the pain that is the reason why your patient is coming to the clinic. So you need to assess the quality of the pain. Is there any associated headache? For example, those that had road traffic accident, if there is whiplash presentation, then there will be hyperextension of the neck. So if there is that, you ask if there is sore throat, because it can easily injure the anterior structures of the neck, whether if there is difficulty in swallowing, then whether if they feel there is something that is stuck in the esophagus. If such presentations are there, then you should know that there are some other soft tissue structures affected in the anterior neck. If the patient is having headache, is there any associated blood vision, loss of balance, tinnitus, auditory disturbance, swelling and stiffness of the fingers, irritation of the sympathetic plexus surrounding vertebral artery, or irritation of the spinal nerve? So you need to also take all this information. Usually there is an assessment form at the end. I have a copy. I don't have the soft copy, but I made the picture from my book. I don't know, maybe some have the form in their assessment centers. So you can easily mark all this, and then it will guide you on how you examine the patient. Then intensity of the pain. It is good to measure the intensity of the pain, because the pain that you may think is serious to the patient is called less. But if you now measure the pain and you see how he assessed the pain in his score, so subsequently when you are reassessing the individual, if he is given less or more, then you can now get the reason why he's given less or more. Is it due to your intervention, or probably didn't comprehend how the pain assessment was done? If he's unable to do this, unable to do that, and then the patient is now having this and that, then you should be able to relate. So in this case, diary may be helpful in chronic pain. Chronic pain has been a pain that has lasted for a very, very long time, usually from 3 months and above, although some literature will say 6 months, but usually 3 months is the most appropriate duration to use. So you can, if you can give your patient diary, then that patient may observe how his pain is improving or is worsening. A simple diary that they can easily mark, maybe daily in the morning and then in the evening. And that's not that the patient has to be preoccupied with the diary that every 1 hour, every 2 hours, every 3 hours, the patient has to fill it. In the morning, it makes sense because sometimes there is morning stiffness, there is morning presentation. So the patient can mark, and then maybe in the evening, after all the activities of the day, when the patient is retiring to bed, if the patient also affects them there. Then the depth of the pain. So you need to get the information, the feel and the thing the patient, the pain is superficial, or the pain is deeply situated into the underlying structures in the neck or in the areas where they present with the symptoms. You need to also get the information if there is abnormal sensation. Then that patient's pain, is it constant or intermittent? Intermittent symptoms are the symptoms that can easily be managed. Constant symptoms are difficult to manage, and then you need to also know if they are constant and still they are unremitting. There may be some constant pain that it's always there, but it is worst when I move. It is much better when I'm sitting quietly, not disturbing me. Then that's a little good pain. But if it is unremitting, then it may be suggestive of neoplasm. So it is a red flag. Probably maybe you have to refer this patient to other specialists. Then relationship of symptoms. If the patient, for example, is presenting with pain in the neck and pain in the shoulder and in some other regions, then what are the relationship? Do they always appear together and disappear together? Or when the patient makes some movement, then one disappears and the other stays there? So if they are always appearing together, then they may be having the same source. But if they can appear independently, then it may be independent presentations of pain. So for the behavior of the symptoms, what are the aggravating factors? What movements and or positions aggravate patient symptoms? That forward, backward, to the side, what happens to the symptom? The patient's pain aggravates. For example, when a patient is now flexing the neck region, and then the pain in the posterior aspect of the neck is getting worse. And when the patient extends, then the patient's pain is getting better. Then probably muscles around the posterior neck region are also affected. With flexion, they are being stretched. Then with stretching, then the area of tenderness is being stretched, and then there may be aggravation of the pain. So is the patient able to maintain the position of movement? This will tell you about the severity. If you ask that, yes, I can be able to flex my neck, but I cannot sustain it. Immediately I flex it, I will bring it back to neutral or extension. So it is telling you that it is very severe. But if the patient can sustain it for a very long time, then it means even if the patient is telling you it is a serious pain, provided he can sustain that position, then it is less severe. Then what happens to other symptoms? Worse? Are they improving? Then how long does the symptom take to ease after the movement or position? If the patient, you ask the patient maybe to flex or to extend, and then the patient's pain get aggravated. So, and then you ask the patient to get back to neutral position. It's normal, or the pain is now back to pre-examination state. If it takes very long time, then there is high irritability of the pain of the patient. Then how symptoms affect functions? You ask the patient, the activities you do at home, at work, or wherever, how is this your neck pain related to them? The patient may tell you if it is an active functions I'm doing at work, I even forget about the pain. So if it is a chronic pain, I will suggest that in this, probably there is a psychological aspect of the pain. That if the patient is preoccupied with other activities, he doesn't even remember the pain. So in the assessment, we may also assess the psychological aspects of his views of the pain, and then probably maybe in the intervention, as it will be discussed with you by my other colleague, probably maybe psychological intervention may be included. As we all know, the current focus of pain management is biopsychosocial, so there is a psychological aspect of it. And most of the therapists practicing in this part of the world, we have still not changed our own mode of thinking about pain and how we also manage it. We always try to allocate a pathology to the pain, which makes our pain thinking to be purely biological, that there must be a biological reason for pain. When in some other situation, a social reason or a psychological reason may be the reason why someone is in pain without any biological reason. And in some situation, the combination of two or all the three, biology, psychology, and then what are the things that when this your patient does, then the patient's pain disappear. So mostly, if it is an acute presentation of pain, these erasing factors are often used in the management till when the patient's pain is much more stable. So what are the movement and positions that ease patient's symptoms and how long it takes to ease them? And what happens to other symptoms? Example, symptoms from cervical spine may be eased by supporting head or neck, while symptoms arising from cervical rib may be eased by shoulder girdle elevation. Because when you depress the shoulder girdle, then you are compressing the thoracic region, and then the cervical rib may be also compressed. But when you elevate, then you are given space for it. But when you elevate, then you are now compressing structures at the upper cervical region. So if there are structures that are affected in the upper cervical region, so if you now increase the space in the cervical region or support the space, then it will make it better. Then what are the 24-hour behaviors of the symptoms of the patient? We have the night symptoms, then morning and evening symptoms. Night usually have to do with the comfort of how someone lie down and how it affects the sleeping of the patient. So is it difficult for the patient to fall asleep? If it is difficult for the patient to fall asleep, then you should know that when you are assessing sleep quality assessment, probably maybe a questionnaire, so that you will now know the level of the sleep hygiene, the sleep quality, and maybe after subsequent management, you can come back and reassess if that sleep quality is improved or not. I think we hardly use this in managing our patients in this part of the world. Then what position is comfortable or uncomfortable for the patient? The patient may say probably maybe he has to remove the pillow and sleep, then that is a relieving position. And then when he uses the pillow, then the pain is worse. So probably maybe there are some stretches of the soft tissues there. So with the pillow, maybe there is more of the flexion of the cervical spine. So the cervical spine need to be then normal sleeping position are the symptoms waking the patient up from sleep, and how many times, if it does in the past week, how many times in a night, and how long it takes to get back to sleep. All these are sleep hygiene questions, and neck pain has much association with sleep affectation. So we need to examine this. What type of pillow is used by the patient, and how many is the patient using? Which type of mattress? Is it a firm mattress? Is it a soft mattress? A moderate mattress that the patient is using? Has he recently maybe changed mattress or changed pillow? All these are questions related to the 24-hour symptoms of the pain. Then for morning and evening symptoms, what are the nature of the symptoms at early morning? Through the day, and a minutes may be suggestive of cervical spondylosis because it is an arthritic change, and in arthritis mostly there may be such early morning stiffness. Then stiffness and pain for a few hours are suggestive of inflammatory process such as rheumatoid arthritis. So in such conditions, it is normal when you make a certain request for laboratory investigation, maybe rheumatoid factor or other things to rule out if there is a certain pathology or not. Then special questions to identify certain precautions or contraindications to the physical examination and treatment. All this we are saying is a Okay, are you with me now? Okay. So to identify certain precautions or contraindications to the physical examination and/or treatment, as I was saying, I said, all what we are trying to do is you only touch a patient when you are sure that it is safe to touch the patient. Sometimes you may do more harm than good touching your patient. We have many physiotherapists that immediately a patient is coming with neck pain, not taking any history, not getting information regarding some precautions. They will try to move the neck. Okay, they will give head compression, head distraction, this, and then they will just give diagnosis. Okay, this patient is having this and may benefit from traction. That is a very poor practice. We have to make sure that the patient is very safe for examination, especially our manual examination, before we go ahead and give this manual examination. If you're asking the patient maybe to do some active movements, that's fine. But passive movements by the therapists, they can be very, very dangerous. So we have to be very careful on that. We have to make sure that this is the right time for the patient to benefit from our manual examination. A clinician must differentiate between conditions that are suitable for conservative treatment and systemic, neoplastic, and other non-musculoskeletal conditions. So if you have been able from all this information we narrated to say that, okay, this patient is fit for physiotherapy assessment and possible treatment, then fine, then you go ahead. If you think, first, if you're sure that the patient needs other medical practitioners' intervention, then just go ahead and send the patient to that. If you are not sure, if you have some other investigations that will make it certain for you, you may require for them. Or you just outrightly also refer the patient for other investigations. For radiological investigations, if it is radiographs that you may use to rule out some conditions, it is fine. But if it is expensive investigations, make sure that there is absolute need for such investigations before you send your patient for that. So I have mentioned that there is need for you to check if there is cervical arterial dysfunction, because with that, upper cervical mobility is contraindicated, and for sure, physiotherapist during neck pain examination, we do such movements. Then upper cervical instability also, so we have to make sure that we know that. So for cervical arterial dysfunction, from the subjective information we have, we should know if this patient is at risk of the cervical arterial dysfunction. And if he's at risk, then probably we need to refer the patient to receive other examinations by other specialists before probably coming back to physiotherapy intervention. Is there any past history of trauma to the cervical spine or to the vessels? Is there a history of migraine type of headache? Is the patient hypertensive for a long time, or you just realized the blood pressure is very high? Maybe the cholesterol level or the lipid level has been confirmed to be high in this patient. If the patient has had other cardiac issues, cardiovascular accident or transient ischemic attack, is the patient diabetic? Then blood clotting disorders. If the patient is having blood clotting disorders, for the dysfunction, any movement will now precipitate the disorders. Then anticoagulant therapy. If the patient is on anticoagulant therapy, then probably is having clotting disorders, because individuals are put on anticoagulant therapy so that they don't develop clots. So age may be an important factor here, because In the developed world, probably physicians put some certain limits of age, that from that age, maybe individuals will put on anticoagulants daily. Then oral contraceptives, long-term use of steroids, history of smoking, infection, immediately postpartum. If your patient is having many of these risk factors, then it is safer to send the patient for other investigations before you now go for any manual intervention. If it is active intervention, fine. Active assessment and active intervention. So these disorders, the arterial dysfunction, may present with ischemia, because usually the blood vessels can be compressed and there may be ischemia, and then the after effects of ischemia may be present in the patient. So there may be pre-ischemic signs and symptoms in the patient. If there is ipsilateral posterior neck pain and hospital headache, then probably maybe there is cervical 2 to cervical 6 root impingement. So in such individual, it is not recommended to easily go for manual assessment of the neck pain. So that is an early sign of vertebral arterial dysfunction. And if it has advanced, then the patient may be having maybe transient ischemic attack, may be having diplopia, dizziness, dysphagia, and other things. So provided the patient has reached that stage, it means has already started developing ischemic signs. So any movement around that area that may compress the artery may predispose the patient to full ischemia and ischemic presentation. Then for internal carotid artery, Horner syndrome, if there is dropping of the eyelid and other things, is safer, you refer the patient. If there is pulsatile tinnitus, we hardly check if there are ear disorders in our neck pain patients, but this is also an early sign of internal carotid artery pathology. And at later stage, there may be transient ischemic attack, ischemic stroke, retinal infarction, etc. Then upper cervical instability is also another issue that we need to take into consideration, whether we should examine the patient or not. Loss of osteoligamentous in
Get the right one.
Disconnection. They no be doing now. It's still awful. Oh, that is it. Okay. Okay. Which person?
Hello? Okay. It's like I'm no longer the admin, so you have to allow me to share the screen. Okay. Is it sharing?
Yes, sir.
Hmm? Okay. Can you all hear me?
I can hear you now, sir.
Problem, we have to start from one network to another. But you have to let me know if maybe you are not hearing me so that I will not be talking while members are not listening. Can someone talk?
Can hear you. We can hear you.
The voice
okay.
Actually not clear. It's interrupting.
Anyway, we are having a serious internet problem here. We have to change from one network to another, one network to
Your voice is breaking.
Oh. So you also cannot hear me well. But some of the participants are saying the voice is breaking.
I think if you try and go ahead, let's see how it goes.
Hello. Hello?
Sir, if you continue, it will be clear.
The voice better now?
Just continue, it will be clear.
It's better. It's improving.
So as I was saying, I said, so we need to, the osteoligamentous integrity between the occiput and the C2, because the odontoid process has that articulation, and then the ligament holds the skull together with the C2. So if that there is that ligamentous integrity, then it can easily disrupt the movement in the neck, and it can cause impingement because there are no intervertebral discs there. So the cervical nerve roots can easily be compressed, and there may be paralysis presentation. So risk factors for the instability, we check for the history of trauma. If there has been congenital collagenous compromise, maybe from childhood, if there are inflammatory arthritis, then we also need to be careful. And also if there is recent head, neck, or dental surgery, it can also predispose to this. So what are the early cervical instability signs? Extreme neck stiffness. When you ask the patient to actively move the neck, there is extreme stiffness that they can move only a little, just like for individuals that are having other stiffness disorders. Then anxiety. When you ask individual to move and is afraid to move, thinking that serious pain is going to happen in the neck region, but the patient is hesitating, the patient cannot move. So if there is that anxiety, then there may be that chance for upper cervical instability. Then poor muscular control. If maybe you ask for some certain specific movements, maybe you ask the patient to go into neck flexion, and then the patient may be side flexing, or even going for then excessive need for external support. If the patient into a cubicle is always asking relative or the spouse or whoever is with the patient to support the neck, or put your wrapper around my neck, put this, asking for support, then you should suspect instability. Report of neck catching, giving way, feeling unstable. If the patient is telling you sometimes you feel like the neck is going to fall down by the side, as if nothing is holding the neck. Then worsening and unpredictability of the symptoms. At any moment, not in the morning, not in easily get worse without. Then that is another self manipulation. Sometimes we tell you the pain by the back in front, and then the patient will tell you the handle position. So all these are, and now go and say, this is a patient that I can easily sit with, clerk, examine, and plan management, then okay. So the present condition will tell you what the patient is expecting. If the patient is mentioning pain, then you should know that the primary thing the patient want its improvement is pain. If the patient is mentioning that he cannot turn his neck to the side, the left side or the right side, then you should know that that patient is more interested in the movement. For degenerative changes and acute pathologies of the uh, joints, then usually the pain is the key reason for the presentation. While for muscular uh, presentations, usually the range of motion. So a lot of patients that probably will come with pain and they are unable to move to the side, they will tell you that I cannot move to the side. I need to turn. So they are not mentioning pain. They are mentioning the range of motion of the neck. So the range of motion is the most important thing to them. And mostly in such cases, they are muscular problems because the muscles are the ones now restricting the movements, because if there are such tenderness, and the main culprit for this is trapezius muscle, because trapezius muscle over the left and the right side, if there is that much tenderness and trigger point, then it limits the rotation to the left and to the right. If there is associated headache, it's not that all the time that when patient has headache that you shouldn't examine. Sometimes cervicogenic headache can be there, so the pain is related to the neck pain. Is not a pathology that you should be afraid of. Then you also ask if there is change in patient's lifestyle recently, if it is for acute pain in the neck. So what has happened to your life recently? Maybe there is change of job, change of shift in the job. Maybe there are some this your patient, this your pain, or this your limitation in movement. Say yes. When I move my neck to this side, then I get some headache. When I move my head to this side, I get uh, pain on the shoulder or pain on the elbow. And then you now notice those movements. Which movements are they? Are they movements that compresses the roots of the brachial plexus? Then you can relate if that pain is related. For example, if a patient is now flexing the head to the contralateral side, so giving space on the neck, then he's now stretching the roots of the brachial plexus. And then there is maybe elbow pain, shoulder pain on that same side. Then you may think it is related, so it may be due to radiculopathy. But if you are now easing compression of the brachial plexus, you are now flexing on the same side. So there is relief in the roots of the brachial plexus and there is still symptoms, then you may need to examine the joints separately. Probably maybe they have separate presentations. Then checking past or relevant medical history, especially maybe if there has been relevant history with the C-spine and related areas. Maybe there were injections there were maybe minor surgical operations, maybe some other presentations. Then history of any previous attack. Is this the first pain or stiffness in the neck you ever had, or you have had these presentations before? And how many episodes? When were they? Cause, duration, recovery. This will tell you if this is an acute presentation, it is a chronic presentation, or a recurrent presentation. Because in the evidence of the treatment, probably maybe you will have recommendation that in acute presentation you do this. In recurrent presentation, you do this, while in chronic, you do this. And when it comes in the cervical or thoracic area. I hope Okay, my slides are not moving.
And also make it full screen.
Slide showing now. Am I on social and family history now?
Yes.
Yes. Make it full screen.
Okay. It's full screen.
It's not full screen.
Then let me share again. Is it changing? These technical problems. And now? Hello?
We can hear you and we can see the screen. But it's not full screen, but I believe we can manage.
But the screen, but my slide
is okay.
No. Moving. Yeah. Yes. Are my slides moving?
Lights are not moving yet. Lights are not moving yet.
Yeah, I can see this technical issue. We are trying to solve it here. But it means I have to exit that one before I join again. Do I have to? How much sharing? Maybe I should exit and then join again. It's showing now. Not on the screen. Still not moving. I have to just exit, I think, and join again.
Okay, what of my slide now? Hello? Hello?
Hi.
Hi. Hi. You're on social family.
Okay.
Hello?
Hi.
Hi. Hi.
We can hear you.
Hello?
That's fine. Thank you.
Hello, can you hear me now?
Hi, we can hear you.
We can
Yes,
hear
we can
you.
hear you.
We are very sorry with the type of the internet we have here.
Hope you want to upload. So it might be.
is refusing to show. Can I send this to you? Maybe if we can view it from your own. It's not. It should be the.
Let's walk.
Or I should close it and then start again. Okay. And now it's moving. These lights don't want to be moving. And for the actual examination, we need there are some guidance on the examination. So we need the slides. The browser. It is inside. Let me see if I can share the slides in the chat so that everybody will just open and then we can talk. Okay. As a guest now, I may not be able to put attachments. Let me see. No, as a guest, I can't send attachments. I would have shared the slides. Enter the chat and see if you can put attachment. Hmm? You can attach, go. You can't make me admin. Mhm. So you are admin. Okay, let me see. Let me check sharing. Check and see. No, I mean my slides, the host. So it was still not moving. Go out of the chat first, maybe. This is unfortunate. Because you can share, yes?
Yes, sir. You have to make me that member. With the participant, you have to make me that.
Okay.
Mbak network yang mana mungkin? Ada begini lah. Yang kan enam. Tadi kan ni saya.
I done this. 95 at Gmail.
Sana tu orang yang boleh nak. Ramai. Ada ni semua. Udah pengen bawa dia. Ibu 100 naira. Bayang baru medical di Isa. Ya. Iyo. Iyo, use the red one. Ke ayaka. Nyong beru sense ido mana manya. Aku ngaya. So medical aku amfen. So bere boken mo do sne ye paru no.
Someone has not muted himself. I'm trying to send the slides so that Rosemary, I think you are unmuted and the sound you are making. macam kuma gani? It's not showing. So do not show this slide. So I have to completely maybe restart the laptop and then just take this risk. How is it now? Progress.
Too much for me. Go be a man to a
Hello, participants. Can someone talk so that I will know if you are hearing me?
We can hear you.
Yes.
Yeah, we can.
Serious network problem. So I shared the slides. I don't know whether if you all have the slides so that I can just go to the slides, open the slide, and then we continue with the presentation. Do you have the slides?
Yes, we have the slides.
Okay. So we can go to slide number 28. Are we there? Can I continue?
Yes, you can continue.
Okay. So after the relevant medical history, then we now have to consider some social and family history of the patient presenting with the neck pain or stiffness in the neck. So if this onset of the symptom has led the patient to be off from work or business, this is very important because it's part of the things probably you measure as an outcome subjectively. If now your patient can resume back to work or to business, and for those that are practicing where health insurance is very strong, you have to give a reliable reason why they should exempt someone from work and insurance should cover it. Then patient's understanding of the cause. This is very, very important. Are you with me?
I can't send any slides, sir.
Yeah, we have serious encounter with the slides. I can't share the slides on the screen. So finally, when we had serious troubles, I have to now make sure that the slides are sent through chats, and then participants download the slides and then open the slides and we continue. Are we together?
Okay.
Yes. So patient's understanding of the cause is very, very important. You ask the patient what he thinks is the cause of this his neck pain or stiffness. Most especially that I'm saying currently, we have to consider psychological and social factors because they can also lead to pain or sustained persistent pain. So if your participant is thinking there is a serious pathology there, most especially in chronic pain presentation, then adequate medical education should be given to the participant. But that is if the therapist is also practicing using biopsychosocial model. If the physiotherapist is of the belief that everything is biological, then probably he will continue to compound the complaints of the patient. Yes, your bones have started eroding away, the disc has shifted, this has done this. All this information in current practice shouldn't be useful terms when explaining things to the patient because they instill fear. And in as much as the patient is getting afraid, then there may be worsening of the condition. And in chronic pain, there is lack of consistent relationship between findings of the biology, like maybe radiological findings, and the complaint of the patient. Many patients will have normal radiological findings, but they are still in pain. And many healthy individuals that don't have pains may have abnormal radiological findings. So if you always relate that to patient's presentation, the patient will always be in trouble. And if the patient believes that there must be a pathology, you also need to educate the patient. Then expectation of the help to get from the therapist. You ask the patient, what does he expect to get from you so that you will know that if you are going to meet up with his expectation or not. If his expectation is not for the pain to disappear, he wants that pathology to disappear, you know that this is something nearly impossible. Because even if the pain has disappeared and maybe you said, are you now in pain? No pain.
but he will still ask you, okay, can we go and do X-ray and see that that thing has disappeared? Then you will now know that still the belief of the patient is about biology. So only if you can convince him that there is lack of consistent relationship between this biology and his pain, then the patient may not get the desired result. Then response of employer, co-worker, family of the patient to the pain. What is the relationship of that? If the employer is thinking that maybe the patient, the employee, is trying to get days off work, is not something that you shouldn't take care of. You have to examine the patient, know that if he's having such issues with the employer, know how to handle it so that you manage the patient as a whole. With co-workers, probably if they are given more work because the patient is having symptoms and the relationship is not so good and the patient is eager to go back to work, you should know how to integrate back the patient to work. And the family also, if maybe it is affecting how he discharges his responsibility in the family. Then coping strategy. We have many coping technique questionnaires to know if the patient is coping well. Ask him when he gets the pain, when the pain is getting severe, what does he do to cope with the pain? You will know if there are tendencies for some patients to abuse themselves or to even commit suicide-related issues. Then hope for return to work business. And when? Is the patient hopeless or is hopeful of full recovery? And how soon is he expecting that? All this should be taken into consideration. Then we go to the next slide. Then now plan for the physical examination. So by all this information you gather, then you will now have hypothetical region and structures to be examined. Probably maybe because of all the information you get, you need to also examine the temporomandibular joint. You need to examine the upper cervical spine. You need to examine the lower cervical spine, the thoracic spine. You need to check maybe the integrity of the muscles. You need to check maybe the nerves, if the nerve roots are compressed or whatever. So now you have all these hypothetical regions that you need to examine, then you now set plan to examine them. Other factors that need to be examined, like maybe the walking and everyday posture, then the vertebral artery, if you still think it's compromised. How should the physical exams be carried out? Should the patient be sitting down? Should the patient be lying down? How do you want to expose the area appropriately to examine? If it is conventional neck examination, mostly in the sitting position, but if you need to examine for other structures, you may maybe modify the position. Will it be easy or hard to reproduce each symptom? In most of the examination, you want to do something to, if the symptom is disappearing or getting better at rest, you want to reproduce the symptoms and see what makes the symptom to be reproduced. Then is it possible to combine some movements? Sometimes maybe when you flex the neck, you rotate the neck. Is it possible to make the combination or not? Then are there restrictions of examination? For example, in severe symptoms, mostly instead of you to try to reproduce the symptoms, you try to get positions and movements that will relieve the symptoms. Now you get the relieving factors, and then based on that, you plan the management. And subsequently, as the symptoms are getting better, then you can now try and get what makes the pain worse. Because in severe symptoms, physiotherapists should not reproduce the pain because they will put the patient in too much pain. Then precautions and contraindications to elements of physical examination, what you shouldn't do and what you should be careful of while making the examination. So the first important question, we are in the physical examination.
We should be calling the number of slides, sir, so that we'll be carried along. Please,
okay.
Sir. Thank you.
So slide 30 now.
Thank you, sir.
Okay. So now the first question now is to the physiotherapist should ask himself is this patient's condition suitable for me to manage as a PT? Even if you are now able to examine, is it a suitable condition for you to manage? It's not maybe a condition that should be managed maybe surgically? my colleague that will present the other part of the presentation based on the evidence. If this is what you are suspecting, and based on the evidence of management, this management, maybe physiotherapy has maybe less evidence, while, for example, maybe surgery or medication has more evidence, then you should know what to choose for the patient. Then the second question, does this patient have neuromusculoskeletal condition that I may be able to help? Maybe the muscles, the joints, the nerves, which are the scope of physiotherapists in the management. Is the patient having severe irritable symptoms? If the patient is having that, then you know you have limits to the examinations. Usually, probably maybe when you examine to the level of the pain, you don't go to the full range of movements for the patient. Then slide 31. So as you conclude on this, then you now start by observing the patient. We know observation starts informally by the time the patient comes in. Then now you go on to start the formal examination, formal observation. So for the observation, you need to expose the structures that you are going to observe. So you initially observe the posture. How is the neck position? Maybe the patient is presenting with a stiff posture of the neck. You will notice as he's moving, the neck is not moving at all. Maybe fixed flexion posture of the neck, maybe chin to chest position. Then observation of the soft tissues. If the neck is exposed, you will now see if the muscles around the neck region, if they are tensed and elevated, or if they are relaxed and the shoulder is depressed. You will observe this. This will give you an idea if the muscles around the neck region are tensed or they are relaxed. Then observation of patient's attitude and feelings. As the patient is sitting, standing, or whatever in the examination cubicle, how comfortable is the patient? How is the facial expression of the patient? Then you make sure, slide 32, you make sure that for the manual examination that you want to go ahead with, you take all the precautions for the physiotherapist and for the patient. That has to do with the position the therapist should assume so that he will also be comfortable, will not predispose himself to any pain, discomfort, and also for the patient. So slide 33. There is joint integrity test that is usually carried out to make sure that all those contraindications for examination and movements in the neck are checked. But as recommended by the developer of the test, it is recommended that specific training is undertaken prior to these tests. So we are not going to discuss much about the tests because they need to be under specific training of experts so that you will not do harm to the patient. Okay, you are able to share the screen? Yeah. Okay, so you can be taking us as the screens are going. So these tests are applicable to patients with mild upper cervical instability. If there is mild one, but because if you suspect serious cervical instability, then you outrightly send the patient to orthopedic surgeons. Not indicated in acute traumatic condition or when subjective indicators of instability are obvious. The tests are positive if there is loss of balance in relation to the head movement. You may pretest them actively. If the patient is moving the neck actively and there is loss of balance, then outrightly you should know that I shouldn't manually examine this individual. Then unilateral pain along the length of the tongue during active examination. If during active movement is having this, do not go on and carry out these tests. Facial lip paresthesia, bilateral or quadrilateral limb paresthesia on nystagmus. Referral or further diagnostic tests are needed in case of positive tests or subjective indicators of instability. Next slide, joint integrity tests. Then the surgical stress test, which have different types, anterior translation tests. All these are under the Petman integrity tests. So which I would recommend if someone wants to go for Petman tests, has to go for a specific training so that he can be able to be conducting these tests on neck pain patient individuals. Then now, if you want to now go ahead for the examination of the movement in the joints, we have active physiological movements to be examined, and then we have passive. Then you start with the active, because active one, the patient is able to control the movements, so he will do them within the limit of his function. And then subsequently, you can go for passive, because usually passive provoke pain, and then they may limit activities of the patient. So you start with the active, and you go within the physiological ranges first before you go for any other test. So you check the quality of the movement. You go for flexion, you go for extension, you go for side flexions, you go for rotations. In each one, you check if there is clicking of the joint or there are noises, maybe crepitations. If there are, I will share also the body chart again. Then you indicate all the findings you get, because all this can be subjective measures for you to see if there is improvement in the management of your patient. Then the range of movements, you may check them objectively or subjectively, the range through which the movements can go actively. Then behavior of pain through the range of the movement, from the initial start of the range through to the available range of the motion. Then how is the pain? Is the pain getting better, or is the pain worsening? Then resistance through the range of the movement at the end of the range of the movement. At the end, usually a resistance is also applied to see how the muscles will react to tension. When you now resist, maybe side flexion, then the side flexors are put into tension. If there is worsening of symptoms, then you suspect muscle affectation. Then provocation of any muscle spasm as the movements are going on. If there is muscle spasm, that is indicating of acute presentations in the muscles. Then passive intervertebral examination. If you finish with the active, then you go for the passive. You also check for the quality. Passively, when you move, is there any crepitation? Is there any clicking? Whatever sound you get the quantity, what is the range? How is the range of the motion? What can be covered by the range? Sometimes we question the validity and reliability of the passive intervertebral examination. For those new in research, reliability is if I do the procedure, if I will repeat it or another person will repeat it the same way, we'll get the same result. In that case, it is a method that is reliable. But if I do it and I repeat, I will get a different result, or someone will follow the same procedure and get different result, then it is less reliable. Then, so these type of tests are less reliable. And then for validity also, ability of a measure to be able to detect what you are interested in. So the validity is also questionable. But despite this, they are being used by therapists and they find them to be helpful to patients. So sometimes you have to weigh the two. What is the evidence with the research and what is the evidence during patient's management? So for the passive physiological movements, you assess if there is hypomobility or hypermobility. Usually C1, C2 flexion rotation is used, the atlantoaxial joint. So you make the flexion, you make the extension, then you see how the range is. You also flex, and at the end of the flexion, you now go for the rotation. You see if it is full range, if there is pain, or there is no pain, it's only limited range of motion, which may be muscular, maybe there is tension, or there is contracture. And in that case, maybe you may go and also assess other neck muscles like sternocleidomastoid and others to see if there are the reasons for limited range of motion in the upper cervical region. So if you are using assessment for the range of motion, usually normal range has to be around 39 to 42 degrees when you now go for the flexion and the rotation. And if it is as low as 32, then you will suspect that maybe there is tension with the neck muscles associated with headache, like cervicogenic headache. And maybe in the intervention part of the presentation, maybe there may be some talks about if neck pain is associated with headache, this is the evidence to manage it. If it is not associated with headache, this is the evidence to manage it. So these are the positions, slide 38. So we can see the therapist is in a very comfortable position now, making the assessment for the passive physiological movements of the upper cervical region. If you notice how the therapist is supporting the neck of the patient, usually 4 fingers are too much for the examination of the chin. So they cover and they give discomfort to the esophagus and the neck soft tissues. So usually the little finger is moved away in the examination while you use the middle 3 fingers to support the chin, while you now use the palm of the other hand to support for the examination. And then you go gently into the flexion, into the extension. For rotation, if there is need for more stability, it may be done in supine line position, as you can see in the other picture. So in each of the movement, you notice if there is reduced range of motion. Is it to the left or to the right? Is it during flexion? Is it during extension? Then if there are crepitations which may be signs of some degeneration, you also need to note them down. Then if you have finished all the available movements, flexion, extension, side flexions, rotations, then you may go to passive accessory intervertebral movements. You also check the quality of movement there, the range of motion, if there is resistance through the range, the behavior of the pain through the range, then provocation of any muscle spasm. This is one passive accessory movement carried out by the therapist. There is a central posterior anterior accessory movement there, and then you will now see a unilateral posterior anterior on the right side of the patient, and you can also have on the left side of the patient. If you are able to get symptoms increased, then the localized joint space, you may start from C1, C2, C2, C3, C3, C4 coming down. So the localized joint space may be the affected joint or the complaint of the patient. So these are the patterns of the accessory movements. You may have central posterior anterior. You may have unilateral to the right or to the left. Then you will have medial transverse. Then you may have medial lateral transverse. And then you may have unilateral anterior posterior. So all this with the component of the joint, you will now know if it is a right side affectation, left side affectation, C1, C2 affectation, C2, C3 affectation, which will guide the intervention you will give. Then sustained natural apophyseal glides as developed by Mulligan. This is also used. It may be used as an assessment tool, and it may also be used as an intervention tool. When there is painful cervical spine, then it is examined in sitting. So in sitting position, the therapist will now apply pressure to each spinous process, the transverse process of the cervical vertebra, as the patient moves slowly towards the pain. If the patient has pain on the right side, for example, and then you now apply the pressure, so it is the same right side that the patient should go towards. And then you examine cervical spine by cervical segment by cervical segment. So symptomatic level will be the one in which the pressure reduces the pain. If maybe C1, C2, you now apply the pressure, the patient goes through the range, the pain is worsening, you come down to C2, C3, C3, C4. So the level through which when the patient moves through the range on the side of the pain is getting better. Then you have positive SNAP test, which means that is the level where the affectation is, because it is hypothesized that with snacks, you relieve the structure that is the culprit for the symptom of the patient. So as the patient moves through there should be a relief. If there is no relief, then that is not the culprit for the presentation of the patient. So this is a position where a snack is applied. You can see how the therapist hold comfortably the head of the patient, and how now he moves in opposite direction. In the first one, how he moves the thumb, and now pushing on the side of the pain of side, so that you will now get where the patient gets the symptoms. So you can see the pressure that is developed using such tests for extension. You can also have similar method for flexion, and if possible, you can also go for side flexors. It's more difficult to get for the rotators because rotation is a different movement that is not unilateral. But for flexion and extension, they are unilateral and side flexions. So, and then the patient can see the progress. And maybe after subsequent sessions, the same thing can be done, and the patient can see how much maybe the muscles have improved in the strength through the sessions. You also check for neurology, the muscles, and then the myotomes. We have studied them practically and theoretically. Because we have spent a lot of time, we don't need to spend more times here. Then neurological tests. If there are symptoms from such examinations of the neck, active and passive movements that are reproduced in the shoulder and down to the upper limbs. So there may be need for you to do upper limb neurodynamic tests. There may be need for SLAM tests. And for the upper limb neurodynamic test, you may also go ahead to do some bias for median nerve, for radial nerve, for ulnar nerve to see if there is affectation of them, and modify the neurodynamic test to see if some of the movements are relieving. For example, if you are assessing for radial nerve at the end, you flex the wrist, then extend the wrist and see if the symptoms is going to get better, which may indicate lower affectation. But if the symptom is not getting better, then up the cervical nerve roots is probably affected. So for emergency, we have already talked about what you need to handle and what you need to refer. Then sometimes a lot of therapists, they request for the radiograph, and I mentioned something earlier. So there is a prediction rule that you may use to know if you should send for radiograph or not. If patient at any high risk factor of, let's say, age of equal to or greater than 65, and there are paresthesia in the extremities, yes, there may be recommendation for the patient to go for radiography. If there is no such risk factor, then are there other low risk factors that allow safe assessment of range of motion? If there are no such, then you request for radiograph. But if there are, you still check if the patient is able to rotate neck actively 45 degrees to the left and to the right. If actively the patient is able to do that, you may not need the radiograph. But if the patient cannot do such, you may need the radiograph if you didn't suspect that limitation to be from muscles. If it is from muscles, from the physical observation you did and the examination, and you realized maybe on palpation, there are tender points around, for example, the trapezius muscles, it may be the reason for the limitation of the range of motion, then you may not need to send for radiograph. You may plan to manage trigger points. So red flags for the neck trauma, tumor, spinal cord compromise, systemic disease, infections. And then, although we manage pain, it is unremitting severe pain. It may be also a red flag. Then prior medical may also be red flags for you. Then range of motion, we have mentioned range of motion that can be measured there. These are more scientific against us. I made for science. A lot of our physiotherapy, they don't examine our clinical patients been maybe I've unmuted myself. Can you hear me? Yes. Okay. So I think because of the time, let's go to the self-assessment. So slide 61. So although we use manual assessment to diagnose the patient, and in manual assessment, we are always trying to find a pathology. And I've already said, it's not all the time that there is pathology before someone can get pain. In many instances, there are no non-pathology related to the pain. We all know that non-specific pain in the spine, be it for neck pain or back pain, is having the highest percentage of the presentations of pain. So we shouldn't always think that there must be pathology that we can relate to before we now manage our patients. So sometimes self-assessment questionnaires that are used, they are very helpful. So you can use them to know the presentations of the patient and how you can help the patient. If maybe the questionnaires, for example, the self-assessment questionnaires that are used for neck pain, there are some generic ones and there are some specific ones. From here, for example, among the specific ones, for example, cervical spine outcome questionnaire, which assesses pain, function, disability, psychosocial status, healthcare utilization. So it can be administered and you can now make the scoring. And then after some interventions, you can now see if the patient is getting better or not. So from there, you can see the level of the patient's pain, you diagnose the level of the function of the pain, the level of the functional, psychosocial status, etc. Then maybe there may be some disability scale. Because of the neck pain, the patient may be disabled. And you now measure the level of the disability. You see how disabled the patient is, and then you set the goals for the management, and subsequently, this can be reassessed. So the table here I mentioned, there are some specific questionnaires, and care should be taken in the administration of the questionnaires. If they are patient should read it themselves and fill it, make sure that patients can understand the language used. For individuals that manage patients that are not fluent in the it is always recommended that if there are adapted versions for the culture or the language of the patient, you administer those questionnaires, because differences Okay, I think the internet is back. Can you hear me?
Yes, I can hear you.
Okay, we
Yes.
are on slide 64, clinical reasoning now. So when should these examinations and tests be carried out? I would love to hear maybe a few comments on this. Hello? Hello?
Hi, sir.
Yes, when should we carry out these examinations, these tests? Are you with me? Hello? Hello?
Hello, yes, we can hear you, but the question seems to be too general. I don't know what to say on that. I think it's necessary to carry out the test when you want to rule out, when you want to delimit conditions, and when you want to get to the diagnosis and diagnosis of the patient. So I don't know how to answer that question. That's why I didn't talk.
That's a very good answer. The only thing is we need to make sure that it is safe to carry out these examinations or tests first. That is why all those things were discussed initially. For neck, it is a very fragile area where movements can easily do more harm than good to a patient that is not fit for the examination. So we make sure that we rule all precautions, contraindications to the tests before we carry out the tests. Then the next question I have, does it always make sense to look for pathology? Because when we are making tests, we are trying to see which segment of the body, which structure, nerves, soft tissues are affected. But does it always make sense to look for pathology? Always. It doesn't make much sense to always look for pathology, because when you precondition yourself that there should be a pathology causing a pain, then the tendency that you will diagnose the patient to have non-specific pain is less, because you are trying by force to get a pathology for it. In acute pain, it makes sense to look for pathology, because this is how the system is built, that you get a reaction of pain to protect yourself because something new has happened to the body. But if it has reached a chronic stage, it has lasted for months, then it doesn't make much sense to always look for pathology. Probably the system of the body is not working well. I will recommend colleagues to read about pain education now, because patients are educated on pain, because the system of pain development in the body can be faulty. We know we have the nerves that take the information from the periphery of the body and they take them centrally, and then they bring the information and the output back. So if there is an acute something that happened to the body, maybe injury, pressure, then the body will, the brain will now interpret it as pain, then the patient will feel pain to protect or to go and look for medical attention. But if it has lasted for long, probably that system has been affected, just like how normal systems can be affected and become malfunctioning. And then with some evidence of some interventions like the educations, so all we are saying is there may be pathology, there may be pain without pathology. Then radiographs and lab investigations for diagnosis, they may be needed if the prediction rule and other plans for examinations are satisfied. But we shouldn't overuse them and we shouldn't rely on them. There is this common practice. Even if your patient comes with a radiograph, maybe they will say they will ease the work of the therapist, they will pass by, get radiographs, get some scannings and bring the result. I've already done this. I will recommend that you only check that when you finished all your examinations, unless if it is a traumatic presentation that you want to rule out, fracture, dislocation, or others. Otherwise, by the time you checked and maybe you see there is cervical spondylosis, then all your mind is towards cervical spondylosis and you may not adequately examine other structures and you may miss a lot of things. Then another question, do we need to also give emphasis in the trunks and lower limbs examination? Because I didn't mention that in the assessment. Can someone respond?
Yeah, thank you very much. It's very necessary. We need to do holistic treatment. So the lower quarter of the body should be screened too, not the upper, not the neck region, head and neck alone. We need to manage holistically. Thank you.
Yes, very good. That is what I expect. And the reason is that probably maybe when the second presenter is presenting, you will realize that probably maybe someone is presenting with neck pain and evidence is showing that if someone is cycling, doing aerobics, is going to relieve the neck pain. So if you have not examined lower limbs and trunk adequately, to know if they are fit for some of the interventions that evidence has shown to help neck pain patients, then you may be in dilemma at the end. You have examined, you have realized this is it, and then now the patient cannot do this. Then you start looking for alternatives. So you examine as a whole, so that if there are interventions that will require exercises of the upper limbs, of the trunk, of the lower limbs that are helpful to neck pain patients, the patient can be able to adequately carry out those examinations. Slide 65 is, I don't have the soft copy of the chart, but I have it in my books, and I have used it when I was abroad. Usually, instead of using conventional folder for patients, then they use these charts. So the body chart, you have already started using it initially when you are assessing the patient. So the patient has marked where and where they have the symptoms. Then you have where you now record the relationship of the symptoms. Maybe the neck pain gets worse with shoulder depression, or with shoulder elevation, or with forward flexion at end range. So you get all those things. The aggravating factors, if maybe this movement is combined with this, it aggravates. And you mentioned if the patient's pain or symptom is severe or is irritable, because if it is irritable, if we didn't see some other examinations, we know it's because of that irritability. Then raising factors or easing factors, you indicate them there, so that any therapist that probably maybe is not you that will continue with the patient will have adequate information. Usually the way we just write those histories and other things, they complicate issues. But if to say we will adopt this method, you can easily go to each of the component and see what you want to see, so that it will guide you in the management of the patient. There is a place for the 24-hour behavior, if it affects his sleep, or early morning stiffness, early morning pain, then factors improving the pain in static position or in dynamic position. Then specific questions, the general health, weight loss, which may be affected, associated with systemic disorders, all those things. Then the histories, you get the history of the presenting complaint, how it started, the past medical history, the social history and medical history. Then what you observed, if there are swellings, if there are signs of tenderness, redness, the joint integrity tests, if the joints are safe for examinations or they are not safe for examination. Then the active and physiological examinations you carried out. Then the muscle strength, if they are weak or if they are strong, the muscle control, then the muscle length, if there is, if they are contractures or not. So all this is giving you highlights of what you need to just document in the form. So with that, you can now clinically say you have finished examining your patient. These are the problems you have seen. And in my initial slides, I said, now you can term the pain or the limitation in the range of motion to be acute, to be subacute, to be chronic. Is it the one associated with movement? Is it associated with radiculopathy? So whichever one you have, then in the subsequent presentation, if they say this intervention of physiotherapy is found to have high evidence in the management of acute neck pain, then since you have now successfully examined and you have arrived that this is an acute pain, then it can be applied to the acute pain. If it is for radiculopathy, this is the evidence of physiotherapy intervention, and this is the intervention of high-level evidence for the management of neck pain with radiculopathy, then you can now go ahead and manage the patient with that. If the patient is having, for example, maybe trigger points in the muscles, and from the intervention presentation, maybe this is the intervention that has the best evidence for the treatment of trigger points, then you can now go ahead and manage the patient. I think I have come to the end of the presentation. We can now entertain some questions, maybe for a few minutes. I don't know, what time is the second presentation starting? Maybe we have to use just a few minutes. Unfortunately, we encountered a lot of internet problems, so we couldn't finish at exactly 1 p.m. so that you will have adequate time to rest before the second presentation. Thank you very much. Ko bana online ne na karasa duk wannan magana. Questions so that we can end the session before the second session. Are there questions from the chat section? Are there no questions? Peter Opala, are you asking about sternocleidomastoid pain syndrome? Usually, for neck pain, we said you assess pain and you also assess range of motion. Usually, sternocleidomastoid muscle pain presentation, one, if you are examining on palpation, the muscle will be painful. So, and typically, you know, the muscle is by the side of the neck, it's not on the real neck. And then during range of motion, contralateral neck flexion and rotation provokes pain. So it is the provoking pain movement. And then on the ipsilateral side, then the pain is relieved, meaning that the muscle is now relieved on that position. So usually if you can differentiate that, then you will now know if the pain is from the sternocleidomastoid muscle or is from the neck. If it is purely from the sternocleidomastoid muscle, if there are evidence in the management of SCM syndrome, you go ahead and do it. If there are none, then from your own experience, then you can now see if management of trigger point along the muscle and other heating modalities that soften the muscle and makes it flexible will release good outcomes. Any more question? So I think it's better we call it a day and allow you to rest for the second part of the presentation. Unfortunately, we had a lot of technological hitch. I think yes, Dr. Uche, that is what I just said. In the definition of the neck that we give, from the nuchal line up to the C7 spine, up to the medial edges of the scapula is considered neck. And pain in the sternocleidomastoid muscle also is felt in this area of the neck. So thank you very much for listening. I pray that we meet more times professionally so that we can learn from each other.
Hello, sir. When are we starting the next session?
Thank you, everyone. Let's have that 30 or 45 minutes break for the second presenter to continue. Let's come back by 2:15. Let's come back by 2:15.
Kawai sai dai mu masu yama manni. Ka bani.
Okay, sorry, na yi muting ina workshop ne, okay. Na ce ban da wallet ɗin in bari haka dai abun ko kuma ko inda zan riƙa taɓawa shine.
Good afternoon, everyone. I don't know if this is happening to me alone. I can't see the video and I can't see the audio from my end here. I hope it's from the
We are about
facilitators.
to start.
Okay, okay. Thank you, sir.
And what should I do? I should share my screen. Share. Share. You don't go on what? What I can control. Yeah. Still sharing. Sharing. So I should go back to the Zoom and video on it. Okay, so I can continue. Hello, good afternoon.
Good afternoon, sir.
Yeah, can we start, please?
Yes, we can start, sir. About 51 of us online now.
All right. Good afternoon once again. My name is Bashir Kaka. I'm Associate Professor of Physiotherapy working in Bayero University, Kano. This afternoon, we'll be talking about physiotherapy management of non-specific neck pain. We have to be specific because there is a lot of other causes of neck pain that this time may not be enough to explain the management of neck pain. But if we're specific, we should be able to take care of this particular cause of non-specific neck pain. And we'll see the level of evidence in the management of non-specific neck pain, the physiotherapy management, and what is the current trend in the management. Then we'll look at one aspect and we'll do some demonstration and we'll call it a day. In the morning, my colleagues has done a lot on the issue of assessment of neck pain. I joined the meeting. He has said a lot, which I may not need to say anything about those aspects. And I will just be focusing on the level of evidence and the management, and maybe the outcome measures that we need to use in the physiotherapy management of non-specific neck pain. I believe during the course of discussion, he mentioned a lot of things about the non-specific neck pain. So let's look at the outcome measures that we can use. I mean, not the outcome measures, the outline that we'll be discussing today. I will start with the introduction. Can you see my screen, please?
Yes, we can
Yes,
see it, but sir, if you can put it on presentation mode, sir.
On
full
Please,
screen.
showing more
all right, let me change it to
full
presentation.
screen. Yes.
Yeah, it's now on presentation. Can you see the whole screen now?
Yes, sir, Prof.
Yes, we
We
can
can.
see it.
Yeah, so we'll be looking at the introduction, the outcome measures used in the management of neck pain, then level of evidence in the management of non-specific neck pain, then the current trends in the management of neck pain, then prevention methods, then we'll summarize everything and we'll conclude and make some recommendation. So let's start with introduction. As we are aware, neck pain is just unpleasant sensation around the neck, which may be result as a fatigue, tension, or pain radiating from the shoulder. The pain can radiate to the shoulder and upper extremities or heads. And we said head and upper extremities, I mean in particular upper extremities, give a support to the neck. So anything that can affect upper extremities can actually affect the neck and can lead to neck pain and can lead to other pathology. So while doing any intervention that you are given for neck pain, you also need to, I believe during the assessment in the morning, you were taught how to assess upper extremities for pain. So whenever you are dealing with pain in the neck, you also need to examine upper extremities. Sometimes patient presents with only complaint of upper extremities, while the major problem is from the neck. So when sometimes you are having complaint of upper extremities pain, either pain in the arm or forearm, you also need to assess the neck to rule out neck pathology. Then what is this non-specific neck pain? We define any pain that is coming from the neck without any specific systemic diseases. We refer that as a non-specific neck pain. So any pain that is coming not referred from the internal organ, non-systemic, is not coming from the spinal cord, either due to metastatic or any other things. In musculoskeletal disorders, we refer that pain as non-specific neck pain. So spondylosis can be referred as non-specific neck pain. I'm just giving you example. Then any other pain that you cannot link it to any systemic diseases, you can refer it as non-specific neck pain. And how does it occur? Usually just occur insidiously without anything. Somebody wake up and start complaining without any other cause. And this pain can be multifactorial in origin. It can be due to posture, it can be due to weakness of the muscles, it can be due to pathology of the upper limb, and any other cause due to trauma and other pathology that can affect the musculoskeletal system. Mostly anything that can affect muscles or bones can lead to a non-specific neck pain. And it's estimated about 50 to 80% of cases are linked to non-specific neck pain because they cannot identify any pathology that is linked to that pain. Then what are the common underlying pathology that can lead to this non-specific neck pain? Mostly poor posture. As we are aware now that we have a lot of gadget computers, phones, any other electronic gadgets that we use can actually change our posture and can lead to non-specific neck pain. Anxiety too had been linked to this non-specific neck pain, depression, neck strain, and sporting activities or occupational activities, depending on what individual is doing for a living. As a physiotherapist too, because sometimes we change a lot of posture while treating our client or while rendering our services. So we are also prone to this kind of non-specific neck pain. Neck pain generally can be classified into spinal pathology, neurological involvement, and non-specific neck pain. So based on this classification, we have 3 classes of neck pain: the one with spinal pathology, then the one with neurological involvement, and the one with no related to either spinal pathology or neurological involvement. Someone may ask that we say neurological involvement. Radiculopathy, is it non-specific neck pain, or can we just classify it as neurological involvement? Can someone answer this question? Hello?
I think we should classify it under neurological involvement.
Radiculopathy can also be classified as non-specific neck pain, except if there is entrapment or there is compression. That is when it goes to under neurological involvement. Thank you for your answer. So numerous structures in the neck and surrounding the region around the neck may be the source of non-specific. In most cases, as I said, muscles or neck or changing in biomechanics of the neck and upper limb can lead to the non-specific neck pain. And we know the muscles, the joint structures like ligament, intervertebral discs, and neural structures are also part of musculoskeletal systems. So these are commonly, in most cases, that we found to be lead to non-specific neck pain. We have the prevalence of this neck pain is usually reported lifetime prevalence between 14.2 and 1 year prevalence between 12 to 34%. And 1 year prevalence in Nigeria is reported to be between 67, 65, and 17% respectively. Lifetime 1 year and point prevalence of neck pain in Nigeria. So which is close to what is obtainable in the globe. And if you look at the figure, this is what is also obtainable in Nigeria. But in most cases, we are not bothered about neck pain. In most cases, people bothered more about the low back pain. But also neck pain is common among the populace, and also people come to the clinic to seek for intervention. Then this neck pain can be chronic, as we used to have a low back pain, and can be subacute. And still, it's not clear what is most effective treatment in the management of this neck pain. We have been seeing a lot of, in the course of this presentation, we're going to see what the literature has said about all the management that we used to do, and what is the evidence base that we can be using as part of our management in treating neck pain that have been presenting in our clinics. As I said, there is a lot of gap in the literature in the management of non-specific neck pain, because we still need more qualities, and this is a more or less area of studies. If someone or those who are doing the PG or anyone interested in carried out study, neck pain is still a virgin area that someone can venture into. So there is still a lot of doubt in the literature in the management of this neck pain. Yeah, the question now is, how do you treat your neck pain? I mean, how do we treat our patient with neck pain? Hello? How do we treat our patient? Am I online still? So
Yes, you can hear you, sir.
Yeah, please, how do you treat neck pain? I want to hear from you. Can someone give me an answer?
I think the first step in treating neck pain is to take a proper assessment.
Assessment, yeah?
Yes, a proper assessment to rule out and also to come to a precise diagnosis. And then you're also going to carry out some tests, such as your distractions or compression tests, Then after you've done your
Depending on the
assessment,
history that you have done. Not all patients that you carried out that compression and distraction.
distraction test, right?
Yeah, if it's fine, it's
Yeah.
unstable, you should not be able, don't even try
Yeah.
that. So after doing that, how do you, I believe you have managed a neck pain in your clinic.
Yes.
So how do you manage it in your own way? I want to hear from you before we see what am I going to say, whether it's in line with what do you manage, or I just need to have an idea.
Okay, from the assessments, if it's, let's
No,
say,
what you do, I just want after the assessment and you find out that this patient can benefit from physiotherapy, and you arrive at your diagnosis, no any contraindication for physiotherapy interventions. What do you usually do in your clinic?
Hello, sir. Hello, sir. Hello, sir.
Yes, I'm with you, sir.
Hello, sir.
Yeah,
Hello?
go ahead, please. Yes.
Okay, sir. Sir, if I confirm that it is non-specific low back pain, and I will look at what limitation the patient is a major issue, like it is a pain with the range of motion, then these two, for the pain first, I will advise the patient to let's use either the ice or the hot packs or hot bottle. Then depend on the severity of the pain. I can also ask the patient to speak to his either GP or the pharmacist to help him with the painkiller. Then the second thing is the exercises. I will prescribe some certain stretching, strengthening, and the range of motion exercises, and isometric exercises to help if the muscles are tight, to stress them, to make the neck more mobile. And if it involves the radiculopathy or it involves the nerve, I can also give him some mobilization. Hello.
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 Hello. Hello, sir.
Hello.
Maybe a quick network issue.
Hello.
Hello, sir. Should I continue?
Hello.
Continue, please.
Then,
Hello? Okay.
apart from the isometric exercises, stretching, range of motion, then before then I will educate the patient about his problem and look at other contributing factors like be it occupation.
Yes, sir.
Hello?
Yeah, you can see my screen.
Hello?
Can you see my screen, please?
No, sir. No, sir.
No, sir. Yes.
Yeah, go ahead. While I'm trying to fix this problem.
Okay, sir. Then, sir, educate the patient on his problem and the possible risk factors that you are able to identify during the assessment, and look at other factors that might be contributing to his problem, and by identifying whether his problem is an acute or chronic, then because if he really understands his problem, that's really the evidence have shown that it will really have an effect on his prognosis because he has the good understanding of his problem. Then I think that that's basically what I can do.
So you are talking based on evidence base
and the experience.
Yeah, that's good. I can see some talks are linked to evidence-based practice. So who can say any other things? Yeah, who was talking before you?
I believe. Hello, sir.
Yeah, please.
Hello, sir.
Go ahead.
I think
Sunday.
Haven't one. You know, yes. Thank you, sir. I want to really appreciate you for this questions that giving us the avenue to speak.
Yeah.
And to me, if I haven't assessed the patient, then study the patient response, how is responding to the pain, and identify to localize specifically the particular that is actually presenting the patient with pain. I think that is one very first important thing that is very important. It's a very good thing for us to identify specifically the spots where the pain is actually located. Haven't identified that pain, I believe in the course of some individual practice physiotherapist wise, some experiences must have shown. Most times there are some evidence-based practice which we give the physiotherapist the avenue on how to approach the patient pain and bring about relief. Most times there could be a situation whereby you have to put the patient in an ergonomic position, haven't identified and localized that pain. Because I'm saying this based on some of the experiences we have gathered so far in our station, that there are some excruciating pain at the neck region based as a result of some certain conditions, which may precipitate that even neck pain. These are some of those assessments of hitherto the patient physiotherapy must have carried out to identify the cause of the pain, aside from even localizing the particular vertebrae that is where the pain is being localized. So I want to identify all these based on our assessment. The approach will not be one, even if the pain is chronic or acute, whatsoever way, one of those approach, because if I should take clear from your, so how do we now approach this? How do we treat? How do we manage? Haven't identified the problem. Now, some of the approach, maybe even at times, if you some use probably cryotherapy, or depends whether you can use hit modalities and all that.
Yeah.
But then, if you look at the natures of the pain, somehow even a chronic pain might actually even be presenting like something that is appeared to be acute, response
of the
the
patient.
acuteness maybe, in some clear, maybe, yes, maybe as a result of the time frame. But when you look at by virtue of assessment, somehow a chronic pain may still be presented as if it's an acute based on some certain features that is going to be presenting with. But that is notwithstanding, the physiotherapy, we have been able to know what particular modality that will suit to actually alleviate that pain, to relieve that pain and the pain reduce, starting to think of any cervical manipulation based on his assessment. I think the best form of it ergonomically is to see how we best position that patient and see how the patient will be able to be comfortable and then receive the treatment and then approach it in such a way that the pain is reduced to a variable minimum whereby you can equally go in for cervical manipulation even before you think of cervical traction, if there's any need for that, and all that. Thank you so very much, sir.
Thank you.
I think that is just basically the areas where I feel wish to. Thank you, sir.
Yeah, so in most cases, if I understand in your center, you do more of either manipulation or mobilization after find out the pain?
Yes,
after
we
assessing
do.
the patient pain, you do more of mobilization or manipulations? Hello?
Hello, sir. I said I do much of.
It's not there.
Hello?
Yeah, I said.
I get your question that you said I do more of manipulation and of
because
traction. It's not really that we go through that manipulation per se. I said I first and foremost find the position that will actually suit the patient for reduce, pain level and bring out modality that can address that nature of pain. For example,
my question is, let's say you have patient with neck pain. So in your center, after all this assessment, what is the common modality, physiotherapy modality that you use to treat the patient?
A pain relieving modality. That's the first thing. But you must manage it.
That's what I want to just hear. All right. So let's see what are the common physiotherapist approach in the management of patient with non-specific neck pain. We have the manual therapy, and I know a lot I can give because of the nature of the spine. You have to get some certification for you to do either. There is a lot of manipulative therapy. We have Wunga techniques. This is common to Nigeria, though all over the world people are using it. We have Metland and other manipulative therapy that we do. So this manual therapy is part of the treatment that we administer to patients with neck pain. But I said manual therapy, you need to be an expert in that manual before you administer it. Looking at the nature of the neck, there is a lot of structures there, and small can render a patient useless. You can do one thing and the whole patient may have spinal cord injury, C7, C5, and the whole manual therapy. Except if you are an expert and you have done certification courses, either Metland, Hungarian, and other techniques that we do in manual therapy. Then therapeutic exercise is also one of the common approaches that we treat patients with neck pain. The reason why I asked you, I wanted to know what you do. Is it in line with what the global practice is? So a lot of you, the two of you that's spoken, they have mentioned therapeutic exercise as well, and someone mentioned manual therapy. If he has seen the patient, will benefit from that. And the electromodalities, which is common to our practice. Most of our patients, when they come with pain, whether low back pain or neck pain, the next thing that some of our colleagues, after the assessment, is to give electromodalities. And we'll see in the literature whether these modalities are effective or can give a lasting pain relief to the patient, or are those just can give a transient. Some of the modalities just give transient relief and the pain will come back, and we'll see which one can give a lasting solution and what the literature is also saying about it. We also have massage and functional training. And a lot of our colleagues nowadays, they don't even practice massage. They leave that to masseurs. And massage is actually effective and is one of the areas that people can do a lot of research, especially if you are practicing physiotherapy. Educational program is one new area. The person, my colleagues that give assessment in the morning, I think he has done neuroscience education as part of his PhD program, and they have seen whether educational program can reduce pain perception or can improve patient among pain. So it's also a virgin area that someone can venture and do research. Cognitive behavioral therapy, CBT, because in the course I mentioned that a cause of the pain can be anxiety or depression. So you also need to go into behavioral approach to treat that kind of pain. So basically, this intervention are the common intervention that physiotherapists practice in the management of neck pain. Either they do it in combination or they do it in isolation. Sometimes patient can only receive manual therapy or exercise therapy with electromodalities, IRR, or massage and other combination. So we'll see, is it combination that is better or single approach? We are going to see in the course of this. There is a lot of investigation to know the practice pattern of physiotherapists in all over the world in the management of neck pains. Some have did some survey and they found out that exercise therapy and manual therapy were common intervention that physiotherapists use in the management of neck pain. So I don't know in your center or in our practice. Yeah, good afternoon. You want to talk, please?
Stable
understanding. So exercise and manual therapy are the common intervention that we use. Physiotherapists all over the world are using in the management of neck pain. But the question remains, which of this intervention is the most effective in the management, or which one that is commonly used in the management of neck pain? And in Nigeria, where we practice, Ayani and et al., they did a study to find out what is the common modalities that physiotherapists use in the management of cervical spondylosis. And I say cervical spondylosis can as well be classified as non-specific neck pain. So let's see the common modality that they use. If you look at the percentage, is mobilizations. Mobilization techniques has the 83%, then massage, tractions, then heating modalities also has 70, apart from massage and neck mobilization, The next modality that physio use in the southwest is superficial heating modalities. So either they do it in combination or single, they use also traction, 50%, then cervical collar. So all this intervention, we're going to see based on the literature. You should understand evidence-based and is different from sometimes what we practice. So we'll look at all this intervention based on the literature and available evidence, whether they are effective or not. And they found out that physios, there is proper way of discharging, and most of our colleagues, they don't discharge patients, or they don't use outcome measure. I believe my colleagues in the morning has mentioned the common outcome measures that you can use if you want to assess your patient after treating him with some physio intervention. So you also need to monitor that. Outcome measures are used for monitoring, for diagnostics, and to keep records that this patient come with so particular pain level, and now I'm discharging it with so particular. And that will also give patients some kind of satisfaction that he came with so, and this is where we are now. And that will also indicate if the patient is improving or not improving. There is need to refer, there is need to invite a senior colleagues to review the patient and change the line of management. So this should be part of our practice. Then let's look at hierarchy of evidence. If I'm looking for evidence, where should I go and look for it? Can someone answer me if I'm looking for evidence? Do I have some answer here? How do you go if you are looking for which treatment is most effective? How do you search for evidence? Elizabeth, can you help us out? Hello? Can someone answer me if I'm looking for evidence? Where should I go? What is the best place that I should look for?
Hello, sir. I think one of the best places to get evidence.
You said?
One of the best ways to get to look for the outcome of researches that people have done.
Yeah, and these researches are also, is the best way to look. And these researches can be grouped into systematic review, randomized control trials, cohort studies, case control studies, case series, and case reports, editorial, and expert opinion. So if you are looking for evidence, the first point that you go is to look for systematic reviews, because systematic review is the highest level of evidence, because they have synthesized a lot of randomized controlled trials into one and summarized everything for you about that particular study. If you cannot get a systematic review, the next is to get RCT, randomized controlled trials. And randomized controlled trials are evidence-based, where you give intervention in one group and other group, you give them another. Cohort studies is just follow up and see where this particular intervention are good or not. The same thing with case control studies. You have a case and you are giving intervention, then you have a control and you follow it up. You have case reports or case series. You can, as clinician, if we practice in the hospital, sometimes we have a case of interest. You just try something and see it is working. And if you want to tell our colleagues that this particular treatment is working, you can report that as a case report. And you said you give so, not knowing that that particular intervention can work. And that can be used as a treatment, and someone can take it up and go and do randomized control trial. Then if you cannot get all these things, because it's the hierarchy, you can get editorial. Someone can write an editorial about one particular intervention or an expert opinion. You can get an expert in that particular field and give a particular opinion, and you can use that, but that is the lowest level of evidence you can get. So this is where we can get, if we're looking for evidence-based, this is where we can get it. We can search from systematic reviews. Cochrane is the common database that you can find systematic review and RCTs. And we have rehabilitation, I think database for rehabilitation. We have Pedro, is particularly physiotherapy database, where you have different RCTs that you can use as an evidence in the management of neck pain. Then this evidence also have a grades. We have grade A is the highest level of evidence. If you have RCT and they said it's a grade A, which means there is no limitation and you have overwhelming evidence from that study. Then if they say that study is grade B, then that's what we call moderate level of evidence. And there may be some inconsistent result or methodological flaws or imprecise result, or there is some issue with methodology. And then you can grade that evidence as grade B. That's moderate level of evidence. Then in this case, most studies are needed in that particular area. For instance, we have neck stabilization exercise, and there is RCT, and they reported is a grade B evidence, which means we need to carry out most studies in that particular area to ascertain that evidence is high or low. But commonly, when you have grade B in that area, that's telling you that most studies are needed in that particular area. When you have grade C, we have lowest level of evidence, studies with lower level of evidence. Above, lower than the A and B, then you need to, you don't rely on mostly in such studies, and that is telling you that area is also burgeoning. Most studies are needed to ensure that we have evidence base. Then how do you monitor neck pain? Can someone answer it? I believe in the morning you were taught how to monitor your patient as part of assessment. Can someone answer it?
Yes, sir.
Yeah, Abbas.
Yes, sir. So what I normally do is I will use some outcome measures and
good
and how the patient subjectively, let's say his level of the pain. Look, when I assess him and the current, what the level of the pain, let's say in the visual analog scale, and the range of motion I've assessed previously, then I will also reassess, and I will ask the patient, let's say in percentage out of 100, in terms of improvement he has following our intervention, what the percentage. If on the first day is 0, no any improvement, and the highest improvement he can get, he can rate the improvement in that. So I would use that to see the intervention I'm giving, it is effective, and how we can progress. This is what I'm doing. Thank you.
So who again in another center, let's hear from, how do we monitor neck pain patients? Amusa. Sarapa.
Yes, sir. Good afternoon, Prof. Basically,
yeah, afternoon. How do you monitor your patient with neck? Where do you practice now?
This is Ibadan.
Ibadan, UI? You I mean UCH.
But
Okay.
actually one of
How
the
do you
outpatient.
monitor patient over there?
Yes, basically, I first of all, at the point
One
of
of the
contact assessment, I first of all, I said I first of all take the measurement at the point of assessment. I use
okay.
training rating scales.
Yeah.
I use yes. Then I also monitor it. Maybe if there is limitation in the range of motion at the initial assessment.
Yeah.
So I take note of all that. If there's need for me to use a goniometer, I do use that. So after let's say 2 sessions, I still measure it. I still measure those assessments that I've done on the first contact. So to
Yeah.
ascertain the how far I've gone, and so basically that's what I do. But on every treatment, I used to ask my patients, how do you feel? So what I do most of the time for
How do
pain,
they feel?
I use yes, I use uh pain rating scale like fast.
Global,
So
the
after the
best
treatment,
scale
I
to
usually
use
ask
for
them.
that. Okay. The best scale to use if
Hello,
you
sir.
want to ask the patient perspectives, how does he feel about his health or about the intervention, is to use global rating scale.
Okay.
Hello?
Hello, I can hear you, sir. Hello?
Yeah, I said the best outcome measure is to use global rating scale.
Okay. Global rating scale, right?
Global rating, yeah, global
I
rating
don't get
scale.
that. Network is not so.
Yes, because you also
Okay,
want
sir.
to hear from, apart from using outcome measures, using pen rating scales, either neck disability questionnaire, anxiety scale, or any other scale. This one, global rating, will give patient ability to rate how does he get better? Is he really getting better or not? That will give you the perspective of the patient himself about what he feel about the treatment. So those that Japa that leave the country, if their practice, I believe in Oimboland, UK and other developed nations, they want to see the global rating, whether they are using it or not. That will give you a patient perspective about his own condition and how he feels about your management. Hello? Are you with me?
Yes, we are there, sir.
Yeah.
Yes, we are with you. Go ahead, sir.
Yeah, so let's look at outcome measures that we use. Because part of the practice of evidence-based is to use outcome measures and see, in most cases for pain, severity of symptoms like pain, we use numeric pain scales, either visual analog scale or adult, or we can use charts for children's. And we can use EMG, electromyography, to also monitor the response of that particular muscles, which is especially more effective in determining symptoms of pain. But in the absence of EMG, you can use numeric pain rating scales. For impact on functional disability, we use neck disability index is the common outcome measure to assess disability. Patient-specific functional scale. Neck disability is specific to patient with neck pain. There is some other, disability outcome that are not patient specific. They are called global scales They can be used, they are not disease specific, so they can be used for any particular condition. But if you want to be disease specific, neck disability index is the best outcome measure to assess for function. Because patient with neck pain can come with issue of symptoms, which is the common symptoms patient report is pain. They can also complain of functional disability, and you can use this to evaluate that. We have psychosocial issues that, because in the course of the presentation, I mentioned that depression and anxiety can be a problems. So you need to evaluate psychosocial issues. Peer avoidance beliefs questionnaires. You can screen for depression. We have a lot of depression skills. You can also screen for anxiety. If the patient presenting with this, then that will give you idea to tailor your intervention towards psychosocial intervention. But if you screen for this particular psychosocial issues and the patient is not presenting with this, there is no need to go into psychosocial aspects. So always, as evidence-based, we practice here, but if you leave Nigeria out of this country, they want to show evidence. And they have a practice guideline. All this one that we do in Nigeria, you have a patient, that is why I asked in the initial, what do you use to treat neck pain? Over there, they have a guideline, and they expect you to follow that guideline religiously. If they said patient come with neck pain, if it is acute, give superficial heating modalities, then give exercise, and so on. So they expect you to follow that guideline. And like UK, they have NICE. NICE usually give, what do I call it? A guide in the management of all the conditions that they have. So they have that, and if you look at their own guideline and look at the evidence base, you see that they are in line with the evidence-based practice. They don't practice anything that they know that it doesn't have, the literature said it doesn't have any evidence. They don't do that. They don't waste their time. They followed that guideline. If they said neck pain, that particular guideline. But what we practice here, we don't have any guideline. It's what you feel that you do to the patient. That's what you venture in. Whether it benefits him or not, we do most of the cases try and error. So let's look at, I have mentioned earlier on, the intervention that we use in physiotherapy management for patients. And part of the intervention, I mentioned educational program. An educational program is a new area now in managing patients with neck pain. And I said my colleagues, the earlier presenter, specializing in educational program in the management, especially they are looking at neuroscience. Now, they feel that if you have a patient, you need to educate him. How does even that pain, how does it happen? What happened in the neck that will lead to the pain? And where does the pain come in? How does it get to the high center? That is why they call it neuroscience education. They believe if you educate the patient, this is what happened when you have pain. You will have better understanding of that pain, and he has a better relief about his pain. And he may not be worried about that particular, because he understands the neurophysiology. So they are trying to summarize it in a, what do I call it? In a low-level language that the patient, even if he's not in the health sciences, you should be able to understand what they are talking about. Neuroscience, if you have pain, how does the pain even happen? How does it get from the point where you have the pain to the spinal cord, to the high center? How does it interpret back? And how do you block it if you take medication or if you give any intervention? How do you block that pain? So they believe neuroscience education has a lot of role to play in the management of neck pain. But still, there is little evidences in this area, and more trials are needed. If someone wants to venture into research, these are kind of areas that you need to venture in. Neuroscience education or educational program in the management of neck pain. As you can see from the literature, educational program employs the experience of patient about his illnesses. And many trials included as not just as single intervention. So that's what it make it difficult to understand whether this particular intervention is effective alone or you have to do it in combination with other interventions. So this is one of the common area that we need more studies. But you should know that educational program is also part of the intervention management in the management of patient with non-specific neck pain. And from what we have in the literature said there is no benefit for educational program as a treatment alone in the management of patient with non-specific. Mind you, I'm only saying non-specific neck pain. Other neck pain may be beneficial to that particular patient. So we need more studies on this area, and it can also be still part of education, part of intervention in managing patients with non-specific neck pain. Manipulation and mobilization. Spinal manipulation is popular. If you look at what I said about what physiotherapists, the global survey of what physiotherapists use in the management of patients with neck pain, the common modality is they use manipulation, mobilization, and exercise. That's the global survey. And if you look at the Nigerian one, the Southwest, where the studies was carried out, manipulation and mobilization also take 80% of the intervention that we do in the patient with neck pain. And based on APTA guideline of 2017, they conclude there is evidence, which is high, there is strong evidence of using manipulation or mobilization in the management of patients with neck pain. So what is this telling us is that manipulation and mobilization are one of the treatment intervention that you can use as an evidence-based intervention in the management of patients with neck pain. And mind you, I say manipulation is not everybody that can give manipulation. You need to be certified in one of these school of thought. We have a lot of school of thoughts. If you go into Hungarian techniques, there is people who are experts. I can mention, what's his name? The one in his name, please. Hello. We have experts in Hungarian techniques, and they do organize workshop on Hungarian. So if you want to be an expert,
yes, thank you, Professor Ego. Professor
Ego, yeah, exactly. He's an expert. Last year he was in Kano. He organized workshop on Hungarian techniques. So if you want to be certified in that, you need to attend his workshop. Or we have Metlands and other techniques too. You can get all those certifications for you to practice those interventions. And they are proven to be effective in the management of patients with neck pain. So based on the recommendations, we are recommended that we can use manipulation and mobilization in the management of neck pain, unlike educational program that I mentioned earlier. And combination of these two with exercise is much effective in the relieving pain. There is some neck pain that come with the headache because neck and head are together, or they can also come with the radiating pain to the upper limb. As I said, upper limb are part and parcel of the management of neck pain because they give a support to the neck. Anything that can affect either weaknesses of the upper limbs or weaknesses of the muscles that cover the neck can also lead to neck pain. So if you are managing patient with neck pain, you need to consider the head, you need to consider the upper limbs, and you need to consider also the muscles surrounding that. As in the course, we are going to see how we do some exercise that can affect both the upper limbs, the neck, and the head together. And at the end of the day, we achieve what we want to achieve in terms of reduction of pain and increasing the functions of the neck. Cervical traction is one of the common machines that physio think of when patient come with neck pain after assessment and they found out that it's a non-specific neck pain and there is no any contraindication, as my colleagues explained in the earlier presentation in the morning. We often use it based on evidence that we have in the clinic, what we call anecdotal evidence, that, okay, patient come and he reported immediate relief when I applied cervical traction. But overall, cervical has not shown to be benefits to the patient with neck pain. And they conclude that based on supported evidence of systematic reviews, that cervical traction is not good in the management of neck pain. If you look at UK, NICE, National Institute of, is it Institute of Guide? I forgot the name of NICE. Sorry, I forgot the particular name. In their guideline, there is no traction. If you look at UK guideline of management of neck pain, you will find out that they don't use traction. But in our practice here, patient get some transient relief when you apply. I could remember my organ in Ibadan, Professor, what's his name? Babatunde Hamzat, not Hamzat, sorry. Amusat, can you remember the name of?
Babatunde Adegoke.
Adegoke, yeah. Adegoke, I always remember. Yes, he said if you use traction now, you claim that traction used to relieve some weight or some compression, either from the nerve or from the cervical spine. So immediately when you remove your traction, those things that you distract, we come back and compress either the nerves or what have you around that area. And the patient will continue to have the pain. But once you are doing it, maybe patient have some psychological, some of these things, they just have some psychological benefit. When you are doing the traction, patient may feel that you are distracting, or if you look at the way for evaluation, distraction, once you returned, you remove your hand from the distraction that is similar to traction, everything will come back. So I think that is why this, you said?
No, you give me a buff food.
So that is why everything they said traction based on the evidence base is not effective in the management of patient with neck pain. So if you are looking for evidence, traction is out of it, but we still use it. It gives some transient relief to the patient, but overall does not cure neck pain. That's the take-home message for the traction. In overall, does not care for neck pain.
Let us say between now and next 3 days, I should be very.
So as we said, traction in most of our facilities and exercise are one of the treatment modality that we use in the management of patients with, but there is a lot of paucity of data on its efficacy. So if someone want to go into research about traction, is also one of the virgin area that we can investigate whether all these things that we're seeing in the long run can traction relieve pain or not. But we use it. But on the evidence base, if to say we have a practice guideline in Nigeria, I don't think you see traction in that. If you go and check for NICE guideline of UK, you will not see traction as part of the modalities that they use in the management of neck pain. Thermotherapy, this is one of also the highest modality that we use in our setting to manage neck pain. There is, on the basis of available literature, thermal remain unproven despite long history of the management of neck pain, but it's still recommended. You can use heat or cold modality, especially in the acute pain or patient that come with the acute and the severe, that is complaining of severe pain. Before you can use your manipulation, you
September 16th. Jesus, 1 month and a half. Wow. They won't allow me to do it. If I divide it now, I will forget it. Because there's nobody, by the time I want to go, someone will go. I can't go. Why he told me to go September and tell me like no, my wife is the end of August, so I will now go July, come back end of August. So wait for what? I told him no, I must be sorry. That is doing it.
Alade, they disturb. Alade.
She still not try yesterday. Try this.
Hello.
In the morning, okay.
Hello?
Yeah, sorry for the hitch. We are having some technical problem there. So we are looking at thermal modalities and their effectiveness in the management of neck pain. We have said this is the common modality that we use, and it's actually effective based on some guideline, National Institute of Health UK guideline. They also recommended using this, but still we need to carry out more studies to find out the effectiveness of this thermal or cold intervention that we give to our patient. Next, electrical modalities like TENS, interferential, and other modalities that use currents. Whether they are effective or not, some literatures has found they are effective, but in the final conclusion, have not demonstrated any benefit in the long run, but they are still being used in the management. And if you find out in most of the guidelines, they don't recommend TENS or any other electrical modalities in the management of neck pain. So we are talking about electrical modalities. TENS and other electrical modalities has not proven to be much effective. So in most of the guidelines, they don't use it in the management of neck pain. So more investigation are also needed. If someone wants to venture in research, you can also look at these electrical modalities. Next is orthosis. Often, most of the time, you see some patient, if it is non-specific neck pain, they use cervical collar. Orthosis have never been shown to be beneficial to those patients. So it's better not to use cervical collar if patient is having non-specific neck pain, except if you want to immobilize that you are suspecting the what do I call it? The spine is unstable, so you can recommend cervical collar. That's for injuries or patient with unstable spine. But for patient with non-specific neck pain, it's not recommended to use such collars has not proven any beneficial effect to such patient. But I said for immobilization, for patient with recent injuries, cervical spines, and other unstable. There is a lot of clinical trials that have been carried out, collar and no collar, and these studies have proven that using cervical collar does not give any benefits to patients with non-specific neck pain. In some instances, they have worsened the situations. So most studies can be carried out for patients with non-specific, because I'm saying for non-specific neck pain patient. Massage, many patients reported temporary reliefs from the pain following massage when compared with other procedures. However, those patients does not get a lasting solution to their problem. So most studies can be carried out, but is good in relieving symptoms, but however does not give a benefits to functional disability of neck pain. Magnetic type to this, but in general, there is no much evidence to support the use of magnetic therapy in the management of patients with non-specific neck pain. Exercise, this is the common things, even from what we have seen globally when they do survey about what physios use in the management of patients with neck pain, mobilization, that is manipulative therapy, and the exercise are the common thing. And even in Nigeria, from what we see in the south, management of neck pain. So we have that impression that exercise is effective. And we have a lot of 1,000,001 exercise that you can use to patient with neck pain. So which exercise? We are going to see the different kind of exercise, and we'll see which one is effective in the management. There are several forms of therapeutic exercise that we can be used for patients with the neck pain. We have stabilization exercise, range of motion exercise, isometric exercise, dynamic exercise, postural training, general fitness program. Some people is because they are not fit that may contribute. We know how exercise can relieve pain, and occupationally directed programs such as work hardening are also recommended in the management. So we have a lot of exercise. And which one do you choose to be? We'll see what, despite. So based on the literature, we said despite the frequency at which exercise is recommended for neck pain and how physio want to use it, physiotherapists want to use it for the management, there is still relatively few RCTs. There is few randomized, and we said based on the hierarchy of evidence, systematic review and RCT are the #1 evidence that you can provide. So we said there is few RCTs, which means this area too is also an area where someone can venture if you want to treat patient with neck pain. So there is a lot of exercise, and we want more evidence about these exercises. And we have mentioned them, so you can decide to do some research if you want to find out which exercise is much effective in the management of this patient. But exercise is also one of the evidence in most of the guideline, either UK, APTA, and other developed nations where they have management of patient with non-specific neck. There is evidences for use of isometric neck exercise, stabilization and dynamic exercise, proprioceptive and re-educational exercise has also been reported to be beneficial to patient when you compare with other patient who has not received exercise. McKenzie approach 2 is also one of the exercise that is commonly used by physiotherapists for neck pain and is also on the basis of identification of directional preference for the spinal movement and can form this directional preference can form the basis for the prescription of this McKenzie protocol. And McKenzie is widely used globally in the management of neck pain for patients with non-specific neck pain and is also proven to relieve symptoms. But many of our colleagues, they don't actually use McKenzie techniques and is not even popular among physiotherapists nowadays. And it's also one of the best approach that you can use. And we need more literature in this area. And what McKenzie did is he has a physical diagnosis. He believes what causes non-specific neck pain can either be postural derangement and dysfunction. So once you are able to classify the patient into these problems, either it is postural problem, and we can see from the causes of neck pain, posture is also one of it. Derangement can be either due to trauma or some other things, and dysfunction. So if you are be able to classify into this, and you can use this preferential, you identify the direction of preference of the spine, then you tailor your intervention toward that. And what they want to achieve, they want to centralize the pain. They believe if the pain is referred, you have a radiculopathy. The pain is referred to either upper limb or some other part of the neck. They want to centralize it to one area. That identification of centralization is one of the key components that shows McKenzie is effective. And it's also well documented that this is effective. But there is limited data or RCTs to support the benefit of this. So it's also one of the areas that someone can venture and do some researches to find out that whether this is effective or not. It remains to be determined whether particular type of exercise are greater benefit than other and whether supervised exercise. Supervised exercise is the exercise that we give to our client in the clinic. They are effective or not. Well, home-based are the one that we prescribe to the patient. Because of the workload, we sometimes prescribe some exercise for patients to be doing at home. So we don't know whether these are effective or not. And we also want to, these are all areas that someone can venture into research, whether exercise on secondary, whether you can use exercise to prevent neck pain. And this has also not been identified. Then behavioral treatments, there have not been, there is also no much RCT. I said this area also need to be exploited. There is no much studies to identify whether it is effective or not. And therefore, the role of behavioral intervention in the management of neck pain is also an open area that physios can go into and determine whether it is effective or not. But there is no much evidence to support this behavioral therapy. What is the current trend? We have seen in the course of this presentation, we have seen different methods that we use. We can use manipulation, mobilization, we can use thermotherapy, we can use TENS, but based on evidence that said only thermotherapy, exercise, and manipulative therapy are effective in the management of patients with neck pain. So now what is the current trend? What do we do in the management of non-specific neck pain? The current trend is to use multimodal approach. Multimodal is in the sense that you can have exercise, combine it with manipulation, combine it with drugs, and at the end, you achieve what you want to achieve is to have patient relief from the pain. So multimodal approach is the current trend. You don't use single intervention. You can combine physiotherapy with drugs or combine manipulations and other exercise or combine drugs with manipulation. And it's a comprehensive program, as you said, where you can combine exercise, pharmacological manipulation, behavioral, and psychosocial intervention. So this is what we refer to as multimodal, and is the current trend. Any treatment of neck pain that does not incorporate multimodal is not the best clinical practice now in the management of patients with non-specific neck pain. So what they advocate, at least 2 different therapy modalities. If you are using exercise, you can combine it with HIIT modality or exercise with mobilization. But exercise is the mainstream that is recommended in patient management with non-specific neck pain. Multimodal approach for patients with subacute and chronic neck pain. They recommend using stretching, strengthening exercise, and mobilization. And this has been found to relieve more pain in patients with subacute to chronic pain. In acute stage, you can use combination of thermal therapy and exercise. But in subacute or chronic, multimodal approach of this combination, stretching, strengthening exercise, manipulation, mobilization, is the most effective and result-oriented when you compare with other approaches. So generally, there is paucity of well-controlled studies in this area. So neck pain is a new, I'm not saying it's a new area, but it's an area that is neglected because of low back pain. Most people are interested in either carried out research on low back pain than neck pain. So most studies is actually needed in this area, and whether multimodal also too, when you compare with other intervention, is better or not. All these are part of areas that we need to venture and see. But generally speaking, multimodal approach is the key mainstream in the management of non-specific neck pain. So this is the current trend. If you want to manage patients with neck pain, go for multimodal approach. Use, if it is acute pain, use thermotherapy or cold with exercises. If it is subacute and chronic neck pain, use stretching, strengthening exercises, and manipulative therapy. This multimodal approach, and sometimes you can add to pharmacological intervention, either in form of topical analgesic or oral analgesics. They are also proven. But when you are physiotherapy, when you are talking about physio intervention, exercise in combination with manipulation is the best approach that you can use. And that is also termed as multimodal. And multimodal means using 2 interventions in the management of neck pain. Then one of the also exercise that is proven to be effective is neck stabilization exercise. Has anyone used neck stabilization exercise? Can someone answer me? Just online. Has anyone used neck stabilization?
Yes, hello, good day, sir. Hello?
Answer me whether he used
Yes,
stabilization.
neck stabilization exercise. If I understand what you meant by neck stabilization exercise, I will want to say maybe it's isometric contraction of the neck muscles, which I've been using
Yes,
very
that's
well.
exactly.
I've been using it very well. It's very effective, very effective. But like most of our doctors, they usually prescribe cervical cola, Philadelphia cola for a patient. But if I know that it's a non-specific, the pain is of non-specific origin, I quickly discontinue cola because the neck
Even
muscle will
from
have
what
been
I
very
said,
weak.
from the evidence,
The neck
cola
muscle
is
will have
not
been very weak.
effective except if.
Yeah, thank you so much. Yeah.
So these
No.
are isometric. How many
Thank you, sir.
isometric exercise do you know? Hello, Miss Henry, Dr. Henry.
Yes, sir.
How many isometric do you know?
Isometric. I know eccentric and concentric.
How do you do it? Because we are going to demonstrate how we
Like,
use it.
for instance, now, if I want to straighten the neck flexors, I put my hand on the. Can you hear me?
Yeah, I can hear you.
I put my hand on the forehead and I ask the patient to resist, to move the chin, to tuck the chin to the chest. Then I can go to the back, to the occiput, and ask the patient to raise the chin up against my hand. Then I can go sideways too, side flexion. Resist the both sides. I resist the both sides too. Then rotation too. I can put my hand between the one hand on the shin and one hand on the occiput, and ask the patient to rotate, to use the chin to touch the shoulder. So these are all the ranges. I do for all the ranges. So I don't know any of other isometric exercises.
Yeah, I'm going to share with you some, because I said anything that affects neck, it also affects the upper limbs. So if the upper limbs are weak, they can also affect the stability of the neck. They have some biomechanics connections. So if you are given this stabilization, because we said exercise is the most effective in the management of neck pain, and we do multimodal, we have looked at all the modalities, like the cervical collar that you mentioned. For non-specific, we said it's not effective, except if there is instability of the spine. So we have this exercise. Have you heard of chin tucks? Have you heard of chin tucks?
Yes, I've heard of chin tucks, to tuck the chin in. Yes, I've heard of it before.
Yeah, so chin tucks is one of the also very good isometric exercise that you can use, and you can put the patient in standing position. This more of for chronic neck pain. For acute, you go for heating modality in the first place. Then later you can go into isometric when the pain threshold reduces. So can you demonstrate pinch? Let me see if I can demonstrate it here. Okay. In standing, usually chin tucks exercise is done in standing position. Patient pull the chin as if trying to make a double chin. You pull his Like, yeah. No, in standing, can you pull your chin inwards? No, inwards. See. You can use mirror as a feedback. Okay, yeah, good. Can you see it? Chin tucks, you hold for some 15 to 10 seconds, relax. Then don't just your chin inwards. No, you're not doing a hand. Go in inwards. Chin only this chin. Then you keep your eyes, yeah, you look at the neck muscles. While doing it, they are more of stretch, or they will go into some contraction if you even touch the muscles. Then patient will hold for like 15 seconds, then relax and repeat it. You do that repetition 15 times in the afternoon, in the morning, and in the evening. You can prescribe it to the patient when you get home. And while in the clinic, you demonstrate, you can use a mirror, standing mirror as a feedback mechanism. And that will relieve a lot of pain, especially the chronic neck pain. Neck is cervical extension. And also this one is done in standing position. You use your hand to grab the base of the neck like this with the both hands. What we want to achieve, we want to strengthen the extensors muscles. While extending the neck as far as possible, you do extension. See, I'm pushing against as much as possible. I'm strengthening my upper limb. I'm also strengthening the neck muscles. You are stretching like this, and you relax. Do it again, relax for 15 times. And you do this in the morning, in the afternoon, and the evening. And this has also proven to be effective. Next is shoulder shrinks. In standing position, patient shrunk the shoulders. Bring them up toward the ears like this. You take it up. What are you stretching here? What are you strengthening? Which group of muscles are you working with? Trapezius.
Should I elevate us? Should I
Yeah?
elevate us? Should I elevate
Yeah,
us?
you call it. Yes, shoulder elevate. Go up. So you are stretching the trapezius because it's covered the neck. Because if the trapezius is weak, the neck muscles too are going to be weak and the neck will be unstable. So you need to strengthen that as well. Shoulder rolls. You do like this. You are also both the shoulder and which other group of muscles that are here? Deltoid. You are, because they give stability to the shoulder. As I said, always when you are taking care of the neck, take the upper limb along because they give stability to the shoulder. And you do this.
Hello, sir.
You said?
Hello, sir.
Yeah, I'm with you.
The way you consider muscle spasm around the while doing the shoulder elevation or shoulder scrubbing, as you can call it. The way consider
what?
The way consider some reserved or residual muscle spasm around that shoulder joint or the shoulder generally, and
if there is muscle spasm,
what does the role what role does it play in performing that action?
No, we don't accept. Muscle spasm is usually brought when there is pain. It's a protective mechanism. Yes. So, yeah, do some patients have muscle spasm when performing this exercise? Maybe need to talk.
Hello, yes, I think the thermotherapy will have taken care of that, like the cryotherapy which you use before the patient begins to do exercises. The cold will have taken care of the spasm, or the heat will have taken care of the spasm, depending on whichever one you want to use. Then you can go ahead with
Most
exercising.
patients with chronic, you don't see spasm. But I want to understand, what is he saying? Is it while doing the exercise that you are expecting patient to have
somehow the muscles tend to, just as we said, it's a protective, muscle spasm is a protective mechanism.
it just present with the spasm, or what is?
Hello, sir. Hello, sir.
Yes.
Okay.
Yeah, I can hear you.
Yeah, I think what he's trying to say is that if there is a muscle spasm, can we go ahead and do this? Hello, sir. Hello.
Yeah, I can hear you. Yeah, I can hear, boss.
I think he meant that if there's a presence of muscle spasm, will the patient go ahead and do these exercises? And I think you have already answered it by saying managing the pain.
You start with
Thermotherapy or cryotherapy, you have already answered that. So if the patient pain level is well managed, then for continue isometric. I think you have already answered that. I don't know.
Okay, sir. That is what I miss, sir. Thank you. Thank you.
Yeah, you can start with thermotherapy and what do they call it, to take care of the pain before going into this. Are you with me?
Yes, sir, we are with you.
Then the next is scapular retraction. You use your shoulder blade. All this because trapezius is very big. It spans through the neck down to the upper limbs and to the back. So you can use this scapular retraction. What we do is to bring the blade together. See the upper limbs, you bring your scapula together, hold for some seconds, relax. Do it again, relax. About 15 times, do it in the afternoon and in the evening. This has been proven to be effective in the management of non-specific, whether it's acute, subacute, and chronic pain. In subacute, that's when you have all this spasm, and it's advised as part of the management to combine thermotherapy or cryotherapy prior to the exercise. And that is why we also call it multimodal approach. Patient can take some, maybe before it was referred to you, if it's come through referral, you may be taking some medications through the clinic. Then you combine it with this. This is also part of multimodal. And in multimodal, you must combine two treatment approach based on this treatment that has been proven to be effective. Then we have the dynamic exercise. Is also meant for like strengthening. You progress, present a weight. Let me go to the next slide. Yeah, we have the reds. And give to the application. Once you elongate it to 100%, it can give about 3.7 pounds resistance. Then we have the green, which is, you can see you are progressing, like you are doing progressive resistance exercise. So once you want to do strengthening, you can start, we have extensions. You can see what I'm doing. You ask the patient to pull back. Or you can put it, I will show some pictures because there is no where I can hang this, but I will show you some pictures. Resistance that you can get around. Patient can use it at home. You can use it well in the clinic. So you can get the red, green, and blue. Blue give more resistance. So you progress from red to green to blue. Let me share this screen. New share. I want to share this how we progress. Can you help me out? Switch is paused. What pause it? One channel energy. Yeah. It's too short. Are you on vacation? Not sure. Internet emails. I should end this show. This is what I'm doing. Yes.
Sir, are you trying to play a video, sir?
Yeah, sorry, I'm trying to show some pictures and the technology is giving us a wahala. Minimize. I want to So before I think, let's continue before you can. So what I'm saying, you can use TheraBand to do dynamic. We call it dynamic exercise or strengthening exercise. You can use extension, neck extension. You can use flexion. Using TheraBand, I wanted to show you how you do it proper. And you can also strengthen chest plate. You can strengthen upper limb using TheraBand for patient with neck pain. So what I'm trying to say, you can use extension, flexion, and upper limb place exercise using TheraBand, different color, red, blue, and green. That's how you progress. You start with the red, yellow, and green. These are two common exercises that had been proven to be effective because we have been saying exercise is effective in the management of patients with non-specific neck pain. So in particular, which type of exercise? We have measured stabilization, we have seen chin tucks, which other one? Shoulder roll, extension, scapular retraction, and so on. So what to share? Is supposed to hold this to the Zoom. I'm gonna kill this.
Assalamu alaikum, sir. Sir,
Alaikum salam.
sir, can we just continue so that if the organizers can share the slide for us after
Okay.
the
Yeah, no problem. Yeah, let's continue.
Yes, sir. Yes.
This.
To save time.
Are you seeing this? Yes. So what I'm saying, you can use TheraBand to do progressive exercise for patients with non-specific elongated. So this has brought us to the end of this presentation, and we have discussed several therapeutic modalities used in the management of non-specific neck pain. We talk about the thermal modalities, electrical modalities, exercise therapy, behavioral therapy, educational program, massage, orthosis, mobilization, and manipulation. And among all this, the most effective is mobilization, manipulation, and then exercise. And this exercise, they are different exercise. And among the one recommended is stabilization exercise. And we have discussed stabilization exercise. We have seen different type, chin tuck, cervical extensions, shoulder shrunk, shoulder retraction, and which other one? And scapular retraction. Then in dynamic exercise also, I recommend it especially with patients with chronic neck pain. And the dynamic is extension, flexion of the neck, We can have side flexion and using weight in form of TheraBand. And I said this TheraBand is of different size, different color, and each color represents the weight or progressive resistance exercise. We have red, the lowest weight you can get from red, then blue, and is it green? And the green, then blue. And we said orthosis like cervical collar or patient with non-specific neck pain does not have anything rather than it deteriorate patient. So except if patient come with an unstable spine, that's when you prescribe. But anything with you identify as non-specific, you don't need to use orthosis. And at the end, we said multimodal approach is the best approach in the management of non-specific. And I said multimodal means combination of one treatment with any other treatment. And we recommend at least to combine 2 treatments. You can combine pharmacological with exercise with manipulation, exercise, manipulation, and the thermotherapy. Especially thermotherapy is good for those patients with acute pain. For patients with chronic pain, strengthening exercise, stretching exercise, stabilization, and dynamic with manipulation can give a best result in terms of patient. And I always recommend you check for guideline in the country where you practice, especially those that practice. Those ones always present a what do I call it? Will push develop a practice guideline for all the particular conditions. I think I have explained this about all the traction, other exercise, mobilization, low power laser therapy. All this require extensive research to find out that whether they are effective or not. So there is few control trial on educational program and other intervention. So people that want to do research, these are more area of research. And don't forget, multimodal is the current trend in the management of non-specific neck pain. I hope you use this practice, and I will share the slide with you. And so that your patient will be happy and smile while treating them. Any questions? Okay.
Yeah, thank you very much, Prof. I appreciate your prowess in the presentation you have given to us. But when we see patients, we treated them, they got better, but they keep coming, We should look into the area of ergonomics. In terms of ergonomics, especially neck pain, majority of us, we look at the computer, we press our phone.
Ergonomic, sorry, I forgot to mention. Ergonomic, I wanted to say part of the preventive strategy. Ergonomic is the best area to use in prevention. It's more of preventive approach in the management of neck pain. And this is also a new area that we can venture into if we want to prevent neck pain. Thank you.
Thank you, sir. We are hoping to have the slides and the record.
Yeah,
Thank
I will share it with. Yeah, I will share it with the organizers and the recording. I think they recorded.
Oh, sir.
Hello, sir.
Yeah, yes.
Hello, sir.
I want to actually appreciate you for this good and laudable presentation. I've actually benefited from your lecture and it has been well educative. However, I think is there any format or protocol that we can adopt? Because from what you have told us from this lecture is that in the other clients where we have, well-developed environments, that's in the UK, US, and what have you that you mentioned, they have specific kind of protocol that they follow in managing
Yes.
some of these. So is there any a guideline in managing specific protocol developed areas? Thank you, sir.
Hello. Yeah, sorry, the network, the thing have been scratching while you're talking. But if I understand if I understand you are trying to say, is there a protocol that we can follow in this area?
Yeah, yes. Hello, sir.
Hello?
Hello, everybody.
Sir.
Yeah, I'm with you, please.
Okay. Well,
He has started, I get what he's saying. Hello, are you with me now?
Yes, sir.
Yeah, if I understand what you are saying, though this thing was scratching while you are talking. Son of challenge. Wallahi.
Hello. Hello.
Yeah, let me finish.
Hello, sir.
Yeah, I can hear you now. Hello.
Hello, sir, Prop.
Yeah, Abbas.
Yes, sir.
Yes.
Thank you, sir, for this very wonderful presentation, sir. We really have a lot of take home and messages from the presentation, and because we now have the evidence, what was proven to be effective when we are confronted with a patient with the non-specific low back pain. So I have neck pain, sir. So I have 3 items just to quickly see. So one, so it is that if we combine the patient education with the, let's say, mobilization and the exercises, can we call this combining these 3 as well, like multimodal as well? If we combine these 3?
Yes, it's multimodal. When you combine exercise manipulation or heating modality, it's also called anything you combine with one another treatment, you can refer it as multimodal.
Thank you, sir. So because as you have
anything more than 2, sorry, more than 2 is referred to as multimodal.
Okay, thank you so much, sir. So because as you have said, the effectiveness for patient education, because when the patient understand his problem, that will really has an impact on his prognosis. So
Yeah.
when we hit our patient, this is what I have identified. The social muscles or the social structures, this is where we might think the problem is. If the patient have this understanding, that will definitely have an impact on his prognosis, and it reduce the fear he has, which might be he thinking that it's a serious problem within the neck or something like that. And so if I get you right, I understand that some of those interventions we have been using, they have short-term effect. While, as from the evidence you have shown to us, exercises, education, and other things, they have long-term effects. So for us to reduce the unnecessary patient follow-up or developing a chronic state, combining using the most effective intervention will be the best solution. Hello, sir.
Yeah, I'm with you. The network is scratching, but I can hear you. You can go ahead.
Okay, sir. Sir, the second thing I would like to speak is for anybody who joined this presentation, we have to reflect on this presentation on our practice. We should look at where we have some gap in our practice so that we can try to fill that gap in order to deliver an excellent care to our patient. So I also ask the organizers, they should please, after this presentation, they should organize a hands-on seminar on this, so that we can see those exercises with the patient, even if not patient, someone can serve as a model. We can see the patient, how you are assessing, how you are demonstrating the exercises, the mobilization. This will really help us in our practice. I hope
I will tell them to. Initially I wanted to say this should have been hands-on, because it will be better if we do it hands-on, you have a better understanding.
Yes, sir, even this aspect we really understand. So the next step is they should organize.
I will talk to the organizers. I will do that.
Thank you, sir. So
then there is one aspect that you talk about. Other intervention that you said is not that they are not working, but they have a just transient effect.
Okay.
Once you treat, you said it too, once you treat them, patient instantly can get relief, but in the long run, those things cannot serve as an intervention. And most thing has to do with evidence-based. It's about what people has done research on. There is some practice that we do, but there is no research. It's just anecdotal evidence. I treat patient, he get better. Tomorrow I will do the same thing and ask my colleagues, you can do this. This is what we call anecdotal. There is no research base that find out that those treatments are effective. And that is why I'm encouraging people that these are virgin areas for researchers. That if you want to do research on neck pain, instead of going into a lot on back pain, we can venture into neck pain with all these modalities that I mentioned, and to find out whether in the long run, those treatments alone are effective. Patient education is a new area now because a lot of researchers are going into that. And that is why there is no much studies, but we do it, we combine it as part of the management. And that is why we call it multimodal approach.
Thank you.
So you can still give patient education, but this one that I specifically mentioned, manipulation, mobilization, exercise, are the most effective in terms of management of patient with non-specific. I'm specific this time around to non-other form of whiplash injuries. Maybe subsequently we'll look at.
Okay. Hello, sir. Thank you, sir. Hello, sir. Hello.
Hello?
If you can,
Hello, sir.
You can organize the subjects. Mun zo da subject. Shi yasa ai na zo nan wuri. Dan in gida nake kaga irin abun
Sir,
sai in yaro na shi yasa ni ce I want to come.
Hello, sir.
So is it still on or we can end it?
Sir, okay. Sir.
Yeah, someone wants to ask?
Yes, sir. Sir.
Yes, go ahead, please.
Okay. Sir, although I was, yes, sir. Sir, we thank you for this wonderful presentation. Although I wasn't participated fully because of some reasons. So, sir, the question I want to ask, sir, I don't know if we can apply cervical traction on a patient with cervical spondylolisthesis.
Yeah, you can apply, but what I'm saying, based on evidence, that one can only give him transient relief. But as long as you remove your traction, all other things will come back. The pain will come back, any other, maybe for a few minutes. That's when you get the relief. And based on evidence, traction has not proven to be effective. I hope you understand what I'm saying. I'm not saying you should stop, but based on evidence, traction is not effective.
Okay, sir. Okay, sir.
Hello, sir.
Yes, please.
Yes, sir. Thank you so much for the laudable presentation, sir. Sir, just based on the last comment you made on the question a colleague asked, did you say we can apply cervical traction on spondylolisthesis?
Not spondylosis, spondylosis.
Okay, sir. Oh, I just wanted to verify. Okay, sir, I want to ask. Though the network has not been final, so I wasn't consistent with this. But I want to ask: is there a need to also look into the curvature of the thoracic region? Since the thoracic region is just like a base where the neck, the cervical stuff sits on. To promote stability of the cervical, that's the neck now. Is there a need to look at the curvature, the proper curvature of the thoracic region? Hello, sir.
Yes.
Hello, sir. Can you hear me?
Curvature of the spine, whether it, what do you supposed to have? No. Yeah, at the cervical region, you're supposed to have lordosis. Then at the thoracic kyphosis, then at the lumbar, we should also have lordosis. Are you with me, please? This network, I understand what you're saying. Let me read it. I think it's the one that was. Yeah, you can assess the nature of the spine, the curvature, whether it is kyphosis or lordosis. Okay, you put on 1 minute then. So based on that, you plan your treatment, whether you are using, what are you saying here, channel or dynamic exercise, or using elective strategy? Yeah, you can do that. You can channel it based on SPNF approach, depending on the nature of the curvature, and the curvature has with the normal, There's lordosis, kyphosis, and lordosis, as we have in the
Shit.
I need to internet in the no, I don't have. This one is connected. It's connected. Warning. No. Okay. The problem is showing. But then it won't work. Okay. You can.
Thank you, everyone, for this long day interactive session. So because of network issues, we are going to cook.
You can share my book.
Thank you, Dr. Hafiz.
Well done, sir.
Thank you, Dr. Hafiz. Please send my regard to our
The recording
lecturer.
and the slide will be shared on the group chat.
Understand? Dr. Hafiz.